फेक बैकग्राउंड।
मेरी आइडिया बड़ा अच्छा है, अगला हम भी ऐसे बैकग्राउंड। लेकिन जयपुर बड़ा अच्छा ऐसा लग रहा है जैसे जयपुर के किसी राज घराने में बैठे हुए हैं।
वो इसलिए जयपुर वाला लगाया है, जयपुर से ही हूं ना मैं।
हाँ गुड गुड।
बस यूट्यूब पे लाइव हो गया, ठीक है, और फेसबुक पे कर दो।
बस धीरे धीरे हमारे सारे पार्टिसिपेंट्स हमें ज्वाइन करेंगे। तब तक अगर देखना हो तो मैं प्रेजेंटेशन थोड़ा सा एक जल्दी से लगा दूं, आप लोग एक एक स्लाइड चेक कर लीजिए। हम कैसे इसको स्क्रीन शेयर कैसे करें?
हो गया फेसबुक तो भी,
ये चलो तभी कर लेंगे, अब तो जो
ठीक है,
आराम से एक्सटेम्पोर।
हो गया।
उनके पंकज सर को लगा
ठीक है बढ़िया।
Endocrinology. आज भी बड़ा एक इंटरेस्टिंग सा केस आया। ये पेशेंट को लेग में पेन था, ठीक है, और कोई प्रॉब्लम नहीं, बस हल्का सा बैक एक। तो अच्छा ठीक है, ऐसा हल्का सा बैक एक, बड़ा नहीं, बड़ा 7-8 महीने अभी आराम से चल रहा। ऑर्थोपेडिक सर्जन के अंडर में थे, फिर उसमें कुछ उसको हल्का फुल्का, वो भी हल्का ही, कोई मेजर पेन नहीं कराया, तो उसको मल्टीपल ऑस्टियोब्लास्टिक लीजन्स थे, एक्सपेंसाइल लेटिक लीजन। ये कैरेक्टरिस्टिक होते हैं जो कि कंफ्यूज करते हैं। ये क्या हमें वो परमिशन देनी होगी, एक परमिशन वाला चक्कर गड़बड़ ना जाए, ध्यान रखना पड़ेगा किसी को, फिर एडमिशन के लिए किसी की ड्यूटी लगा दो। हेलो सर, गुड इवनिंग, कैसे हैं आप? हेलो भाभी, वेलकम। हेलो डॉक्टर पार्थो,
Hi.
nice to see you. May I request you to have your video on so that we can see your face also?
Sure.
Thanks.
Hi.
Hello, hi. नमस्ते सर, संदीप सर नमस्ते, पंकज सर नमस्ते।
नमस्कार, how are you?
मैं बढ़िया सर, आप कैसे हैं?
हाँ बढ़िया, नाइस।
हाँ, नमस्ते पंकज सर, आवाज आ रही है आपको?
मैम नेटवर्क प्रॉब्लम मुझे ही आ रहा है कि आप लोगों को भी लग रहा है?
हाँ, मेरे यहाँ से तो अभी फिलहाल ठीक है, टच वुड।
हेलो डॉक्टर पंकज, हेलो।
सर को भी शायद अभी कुछ नेटवर्क। ओके
जी नमस्कार।
नमस्ते सर, कैसे
हाँ
हैं आप?
पंकज जी, आवाज आ रही है? डॉक्टर संदीप जी।
हाँ नमस्कार, कैसे हैं?
सर बढ़िया बढ़िया। आपकी टॉक तो अभी भी लोग याद करते हैं सर, मेरठ वाली।
अरे आपका बचपन है, आप ऐसा कह रहे हैं।
नहीं सर, बहुत बढ़िया, बहुत बढ़िया सर। नाइस सर, नाइस टू सी यू।
ठीक है। हाँ डॉक्टर सुजी, बिल्कुल हड़बड़ करके मैं अभी ज्वाइन कर पाया आपको।
सर फिजिशियंस का यही हाल होता है, फिजिशियंस को तो बिल्कुल मौका नहीं मिलता। सर आप आ गए, यही बड़ी बात है सर। थैंक यू वेरी मच सर। सबसे डिफिकल्ट काम होता है सर फिजिशियन का।
हाँ, ये कहने के लिए तो अच्छा है।
नहीं सर, बिल्कुल मैं तो बहुत अप्रिशिएट करती हूँ कि मतलब आप लोग कैसे इतने अच्छे से सारे पेशेंट्स को मैनेज कर लेते हैं, और आप अच्छी खासी ओपीडी होती है सर, बिल्कुल। और इम्पोर्टेंट जो मुझे सबसे अच्छा लगता है कि यू आर सो एकेडमिकली साउंड। मतलब ऐसा नहीं कि सिर्फ पेशेंट देखना है, मतलब यू आर हर जितने फिजिशियंस को मैं जानती हूँ सभी के सभी एकेडमिकली इन्वॉल्व रहते हैं बहुत ज़्यादा। ये सर मुझे बहुत इंस्पायरिंग लगता है।
सारे ऐसे ही, नॉट ओनली फिजिशियन, एवरीबॉडी।
नमस्कार शरद सर, थैंक्स फॉर ज्वाइनिंग अस।
हेलो डॉक्टर शरद, हेलो।
ये सर पॉल सर का मैसेज आया था, उनको लिंक ज्वाइन करने में थोड़े से इश्यूज आ रहे थे, बट मैंने सर को रिपीट लिंक भेज दिया, होपफुली अभी वो ज्वाइन कर लेंगे। हमारे साथ हमारे एक गेस्ट फैकल्टी डॉक्टर पार्थ मुखर्जी जिनने ज्वाइन किया है, डॉक्टर विमल अभी मेरे ख्याल से ज्वाइन कर रहे होंगे, उनको मैं मैसेज कर देती हूँ। यूजुअली एज अ प्रोटोकॉल वी टेक अराउंड 5 to 7 मिनट्स। सम प्रॉब्लम बता रहे हैं, तो एक काम करो, सर का नंबर तो है ही, निर्णय को करो कि वो सर को ज्वाइन करा दे और डॉक्टर विमल को ज्वाइन करा दे। सर का नंबर है, निर्णय से बात करो, फिर फोन डॉक्टर पाल और डॉक्टर विमल दीक्षित। एक्चुअली सर आज का टॉपिक जो है जैसे कि आप सब लोग को पता है कि ये बहुत इम्पॉर्टेंट टॉपिक है। अगर मैं इसको रिकॉल करूं तो मेरे अपने ही बहुत सारे रिलेटिव्स हैं जिनको इस तरह की प्रॉब्लम है, और बहुत सारे पेशेंट्स भी हम आए दिन इनकाउंटर करते रहते हैं रिगार्डिंग ये। तो बहुत सारे इश्यूज हैं, अब जैसे कि अब इसका सर्टेन एस्पेक्ट हम लोग भी डील करते हैं एज एन एंडोक्रिन सर्जन, एज एन एंडोक्रिनोलॉजिस्ट, तो ऐसे बहुत सारे इश्यूज हैं। तो ये एक बहुत अच्छा सा मुझे फिर प्लेटफॉर्म लगा रिसेंटली व्हेन आई मैनेज द पेशेंट, आई थॉट व्हाई नॉट टू टेक अप दिस पॉइंट एज अ मुद्दा, हम इस मुद्दे को एक बार हम डिस्कस करें। एंड आई एम सो ग्लैड आई have such a nice faculty. Dr. Vikas Giri helped us a lot, Dr. Reena, and all my co-speakers. And in fact, yesterday I had a very terrible day, and I'm so thankful they all helped me despite being so late and all. So we are just in a process कि हमारे chief guest, हमारे जो guest faculties हैं, 2 guest faculties, they are about to join us, and as soon as they will join, and we will start our meeting. Dr. Partha, can you please help me? If possible, can you share your link with Paul sir, because he messaged me that
Yeah, sure.
his link is not working. So
Right,
at
sure.
least your link he will be able to
Yeah, sure.
join. हाँ. Hello, hi Sarita ma'am, how are you? Nice to see you. डॉक्टर विमल से बात कर लेते हैं, पर नंबर दे दिया विमल दीक्षित, हाँ मैं बोल देती हूँ पर। हेलो आ जाओ आ जाओ आ जाओ आ जाओ, हाँ ओके ज्वाइन कर लो, फिर चाहे तो देखते रहते। ओके बाय सर, कॉन्ग्रेचुलेशंस। अरे खुला ही है। Okay. पॉल सर, मैं बात कर लेती हूँ। Hello, yes sir, yes sir.
ठीक है
Okay, okay sir.
हाँ मैम
No problem sir. Okay sir.
लाइन पर है मैम द्वारा स्क्रीन शेयर नहीं हुई है इसे दोबारा करनी है इसे ऐसे रहने दीजिए इसे रहने दीजिए वो काफी पता है
Okay, so actually Paul sir had an older version. I think sir has joined. Sir has joined.
लाइन पर होगी
Accept. Okay. Good evening, sir.
Hello, hi Sudhir. Yeah.
Good evening. Nice to see you, sir. Thank you very much for joining us.
Yeah.
Okay, so
अब बात कीजिए
is it working?
चल रहा है इसे रहने दीजिए अब बात कीजिए
Okay, so we just another 1 minute more for Dr. Vimal to join. Actually, he had an emergency. Otherwise, we will just start our procedure.
ये स्क्रीन रहने दीजिए
मुझे डिस्टर्ब
बस एक मिनट हो गया
Okay, fine. Thank you very much. Actually, my technical team was taking some time for making our video live on Facebook and YouTube. मेरी आवाज आ रही है आप सभी को? हेलो, इको तो नहीं हो रहा? इस पे ऑन करना.
There's too much of disturbance.
Okay, am I audible to everyone?
Yes, but there's too much of disturbance. Maybe because the mic is open maybe.
Okay.
Not clear voice.
Not clear. Not clear. Should I come close? Okay, is it okay now? Screen share कैसे होगी?
मम्मा उस पर क्रोम पे
Chrome. Chrome.
वही खोलिए मैम वो खोलिए
Screen share.
वो आपने डाला इसमें डाला इस पर ये आ गया खुला हुआ है
Please आप एक बार चेक करो. हम स्क्रीन शेयर करते हैं. We start.
खा दिया इसने
Screen share. My presentation. I have to start.
अरे मैम की जो प्रेजेंटेशन है वो कहाँ डाली है उसे स्क्रीन दिखाओ ना वो वाली स्क्रीन दिखाओ जल्दी हाँ कहाँ डाली है
Screen.
हाँ ठीक है हो गया
Yeah. So hello and welcome to yet another session of Randos. For those who have joined new, Randos is the Breast and Endocrine Society of Western Uttar Pradesh, where on a monthly basis, on the last Friday of every month, we all meet together as an online forum and we discuss about the breast and endocrine related cases. On even months, we discuss about the breast cases. On odd months, we discuss about the endocrine cases. And November being an odd month, this is the time for us to discuss an endocrine case. So friends, this forum is very interesting and very unique in its own sense because it is an integrated program. Here, We pick a problem, we pick a case, we identify the problem, what we want to exactly learn from that case. And with the help of all the specialists, be it pathologists, radiologists, nuclear medicine physicians, or any other specialities who have ever been involved in the management of that case, we come close, we come together, we discuss about the case, we pick our learning objectives, what we exactly want to learn from that case. And with the help of a brief literature review and with the help of guest faculties and a lot of discussion, we try to find out our answers so that we can enhance our clinical perspective and a better patient management. Okay, so this is how we try to improve ourselves. Not only that, like suppose pathologists and radiologists, they also get to know about how their reporting have impacted the clinical management and the ultimate outcome of that patient. And the other specialities also, they get to know about their role and how they can improve further to improve the patient management. Such type of patient, if they come for another time, then their understanding improves in such type of patient. So this forum is very unique in its own sense because we see the patient as a whole. So we provide a holistic view. We try to make it very simple and interesting so that even the common masses can, a general physician or surgeon, they can also understand well. So this time also we have come up with a very interesting topic, that is recurrent nephrolithiasis. Friends, there are certain subset of patients which can be cured if we can identify those patients, and with some endocrine manipulation we can literally cure those patients. So there is an unexplored symbiotic relation which is still unexplored, and in this forum today we will try to explore the possibilities so that we work in unison to upskills ourselves as well as to improve the patient management. Okay, so without wasting much time, I would like to introduce our moderator, Dr. Pankaj Agrawal. Dr. Pankaj Agrawal need no introduction, but still there are many of our participants who have joined from remote parts of the country. For those, Dr. Pankaj Agrawal is the head of the Human Metabolism and Department of Endocrinology, LLRM Medical College, Meerut. He is a great academician and he is the pioneer of Hinglish, that is Hindi plus English education. This type of education makes the subject very interesting and something like the daily routine discussion that we usually used to have with each other. So he is the pioneer of English, a medical concept in Hindi, and which is running successfully, and it is being recognized by our Honorable Chief Minister Yogi Adityanath ji. Also, he is felicitated for the same. And I request sir to now take over the stage and to start the program. Thank you, sir.
धन्यवाद डॉक्टर सुधीर, और मुझे बुलाने के लिए। मुझे आशा है कि आप मुझे अनुमति देंगे कि मैं हिंदी में इस प्रोग्राम को कंडक्ट करा सकूं।
बिल्कुल बिल्कुल सर, ये हिंदी इंग्लिश दोनों प्रोग्राम है सर। ये इंटरेक्टिव प्रोग्राम है, जिसमें कंफर्टेबल है हम उसमें बात कर सकते हैं।
धन्यवाद।
थैंक यू सर।
मेरा मानना है कि यदि हम अपने साइंटिफिक प्रोग्राम्स को भी अपनी सरलता और सहजता से अगर हम कर सकें तो शायद हमारा इन्वॉल्वमेंट भी उसमें अच्छा होगा, हमारी बात को कहने में और किसी की बात को समझने में उसमें भी सरलता होगी, और आउटपुट जो अल्टीमेट रिजल्ट है हमारा किसी भी एजुकेशन प्रोग्राम का, वो उससे बेहतर हम प्राप्त कर सकते हैं। ये मेरा 20 वर्षों के ट्रेनिंग प्रोग्राम्स का और 5 वर्षों से उसको पूरी तरह से हिंदी में करने का ये जो अनुभव है, उसके आधार पर मैं कह रहा हूँ। डॉक्टर सुधी का आभारी हूँ, उन्होंने ये मंच बड़ा अच्छा बनाया और इस मंच में मुझे निमंत्रित किया। जो सबसे अच्छी बात है, अधिकतर हमारी अधिकांश एक्टिविटीज यूनिडिसिप्लिनरी होती है। वो एक ही डिसिप्लिन में जब हम काम करते हैं तो उसकी जो खूबियां हैं वह यूनिडायरेक्शनल बढ़ती है। जब हम डिफरेंट स्पेशलिटीज को साथ में लेके चलते हैं तब हम कई वो पहलू देखते हैं किसी भी रोग के, जो हम अधिकतर एक डिसिप्लिन में काम करते हुए उसको भूल जाते। यदि मैं कहूँ कि 3 दिन पहले मेरे पास एक पेशेंट आई दिखाने और उसका फ्रैक्चर शेफ्ट ऑफ फीमर था और वो नॉन यूनियन में जा चुका था। 1 साल से वो ट्रीटमेंट ले रही थी। जब हिस्ट्री ली उसकी तो पता चला उसको रिकरेंट नेफ्रोलिथियासिस हो चुकी थी पहले। उसके लिए सर्जन से इलाज होता है। जब 1 साल से फ्रैक्चर फीमर हुआ उसके लिए इलाज होता रहा ऑर्थोपेडिशियन से, और कभी आवश्यकता नहीं महसूस हुई कि हम उसका कॉज क्या है वो देखा जाए। अच्छा, हमारे पास जो पेशेंट आते हैं हम भी उनका अपनी अकल से इलाज करते हैं, हम उसका दूसरा पहलू कई बार नजरअंदाज करते हैं। आवश्यकता तो है इंटरडिसिप्लिनरी अप्रोच की, लेकिन हम सब उसमें कहीं ना कहीं कुछ ना कुछ कमी छोड़ देते हैं। और यह जो एक मंच है जहाँ पे कई डिसिप्लिन साथ साथ हैं, इसमें डेफिनेटली हम एक दूसरे की जानकारी को लेते हुए अपने काम को बेहतर बनाने का प्रयास कर सकेंगे। और जो आपने बात कही कि पेशेंट हित में पेशेंट सेंट्रिक अप्रोच, जो डिजीज सेंट्रिक या स्पेशलिटी सेंट्रिक की बजाय जब हम पेशेंट सेंट्रिक होकर सोचेंगे तो डेफिनेटली वो बेहतर काम होगा। डॉक्टर सुधी, इसमें मुझे जिनको इंट्रोड्यूस कराना एक बार बताएंगे, मुझे उनके विषय में कहाँ जानकारी मिल जाएगी?
सर ये फ्लायर में आपको मिल जाएगा।
तो ये मैं नेक्स्ट स्लाइड जो आपने फ्लायर भेजा उसमें से,
यस सर।
तो जैसा कि मेरी जानकारी है अभी इस मंच में हम लोग यूरोलॉजिस्ट और एंडोक्राइन सर्जन ये दोनों का जो मुख्य योगदान है उनके साथ में हम लोग जुड़े हैं। और जो थोड़ा सा पार्ट मेरा आता है, मेरा कोई रोल ज्यादा नहीं है, लेकिन कहीं कहीं शायद मैं आप लोगों के लिए कुछ उपयोगी हो सकूं कि उसमें एंडोक्रिनोलॉजी का रोल कहाँ आता है। वो हम तभी समझ पाते हैं जब हमारे कुछ केसेस में हम अपने सर्जिकल प्रोसीजर से कर लेते हैं, लेकिन जहां मेडिकल एस्पेक्ट्स उसमें बीच में इन्वॉल्व है वह हमें जानने की जरूरत है। तो जैसे कि मैं देख पा रहा हूँ इसमें हमारे साथ आज 3 गेस्ट फैकल्टीज हैं। डॉक्टर विमल दीक्षित जो एसोसिएट प्रोफेसर हैं यूरोलॉजी के SGR में और हॉस्पिटल में देहरादून में। डॉक्टर MJ पॉल जो प्रोफेसर और HOD हैं। मैं दोनों के विषय में बहुत तारीफ सुनी थी मैंने डॉक्टर सुधी से जब मैं डिस्कस कर रहा था, और मैं आज मुझे उसी बात से बड़ा एंथुसियाज्म है कि मैं इन लोगों के साथ सेशन शेयर कर रहा हूँ और मुझे कुछ सीखने जानने को मिलेगा। डॉक्टर MJ पॉल प्रोफेसर हेड डिपार्टमेंट ऑफ एंडोक्राइन सर्जरी CMC बैंगलोर से, और डॉक्टर पार्थो मुखर्जी एसोसिएट प्रोफेसर यूरोलॉजी दोबारा CMC बैंगलोर से, और डॉक्टर सुधी तो हमारे साथ इसमें रहेंगे ही। ये प्रोग्राम को मैंने पहले भी जो अटेंड किए ये समराइज बहुत अच्छा करती है, इसलिए मैं चाहता था कि आज का प्रोग्राम ये यही करती तो ज्यादा बेहतर रहता है। लेकिन आइए फिर कार्यक्रम आरंभ करते हैं। डॉक्टर विमल दीक्षित को मैं निमंत्रित करता हूँ इसमें अपना डेलिब्रेशन देने के लिए। डॉक्टर विमल दीक्षित।
यस सर। ये प्रोग्राम शुरू करने से पहले मैं थोड़ा सा डिटेल देना चाहूँगी। बेसिकली हमारे साथ 3 गेस्ट फैकल्टीज, एमिनेंट फैकल्टीज इस बार हमारे साथ जुड़े हैं। डॉक्टर MJ पॉल, ही इज द हेड डिपार्टमेंट ऑफ एंडोक्राइन सर्जरी एट CMC Vellore. He is a gem, what I must say, a very great personality with such a humble nature that the beyond words. So I am very, very grateful sir has taken out time, and I am looking forward that we will have a very, very good discussion after the presentation. Dr. Partho Mukherjee is professor, associate professor at CMC Vellore, and he is very kind enough that he accepted our invitation, because this program is basically related to urology, and without a good urological discussion from the urologist point of view, we may not be able to achieve the learning aspect that we want from this whole exercise. Dr. Vimal Dikshit, he is my very good friend. I don't see whether he has joined or not, but he was in an emergency, but he will join us soon. And he is also a great academician, a very practical urologist, and I'm sure that he will...
आप लोगों से अनुरोध है कि कृपया अपना स्पीकर ऑफ कर लें, जिससे वो बीच में डिस्टर्ब न करे। स्पीकर का ही केवल माइक ऑन रहे तो बेहतर है। जी
थैंक यू सर। और मुझे पूरी आशा है कि वी विल बी गेटिंग अ वेरी गुड फीडबैक फ्रॉम द यूरोलॉजिस्ट सो दैट वी कैन एक्सचेंज आवर इंफॉर्मेशन टू बेनिफिट द पेशेंट। प्रोग्राम शुरू करने से पहले, फॉर्मल शुरू करने से पहले कुछ इंपॉर्टेंट इंस्ट्रक्शंस मैं देना चाहूँगी हमारे व्यूअर्स को। फर्स्ट ऑफ ऑल, इन केस अगर आपका कोई आपका जो मीटिंग है वो इंटरप्ट होता है ड्यू टू एनी रीज़न, यू कैन रीजॉइन अस बाय क्लिकिंग द सेम लिंक। आप लोग अपने अपने माइक्स ऑफ रखेंगे, सिर्फ स्पीकर्स के माइक ऑन रहेंगे। बाद में जब डिस्कशन होगा तब मॉडरेटर आपको अलाउ करेंगे आपके माइक्स, तब हम ऑन कर सकते हैं एक ओपन डिस्कशन के लिए। इसके अलावा आपको इन बिटवीन कोई भी क्वेश्चंस अगर आपके दिमाग में आता है, विद योर नेम यू प्लीज राइट योर क्वेश्चंस इन द चैट बॉक्स. Our moderator will help us. He will note down all the questions. After the presentation, you will be given the chance that your question will be asked from moderator to the faculties. So everything will be answered. Okay, and at the end you will be given an opportunity to interact directly with the guest faculties or any of us if you want to.
Voice is not clear.
Okay, तो एट द एंड हमें अपॉर्चुनिटी मिलेगी कि आप डायरेक्ट क्वेश्चन भी फैकल्टी से पूछ सकते हैं. सो नाउ विदाउट वेस्टिंग मच टाइम, नाउ आई स्टार्ट द दिस प्रोग्राम, दिस प्रेजेंटेशन. अब ये प्रेजेंटेशन दिस प्रेजेंटेशन इज अबाउट अ फीमेल जो 41 ईयर ओल्ड फीमेल है, multiparous premenopausal lady who had a history of bilateral recurrent nephrolithiasis for past 13 years. Since 2009, she was producing the stones again and again, either in either kidneys, for which उसको बार-बार lithotripsies and PCNLs offer किए जा रहे थे. And she was considered an endemic stone former and never was worked up for recurrent nephrolithiasis. At least whatsoever records that we received and the history, she was never worked up for that. But this was not her main complaint. Her main complaint started in 2012 when she noted a multinodular goiter. That nodular goiter was initially painless and gradually progressive, but it showed a rapid increase with mild pain for last 1 to 2 months. पिछले 1 से 2 महीने में वो rapidly increase कर रहा था, जिससे उसको choking sensation शुरू हो गया था. उसको
Dr. Sudhi, your voice is not clear.
अरे डॉक्टर सुधी, अगर ये आपकी शायद स्लाइड्स भी हैं तो स्लाइड्स को भी रन करते जाइए साथ में, अगर डिस्क्रिप्शन पेशेंट का है उसमें.
Okay,
Your voice is not clear.
I'm sorry sir. तो क्या मेरी स्लाइड रन नहीं कर रही है अभी?
अभी स्लाइड्स रन नहीं हो रही थी उनको. हाँ, यस, नॉट विद इसको फुल स्क्रीन कर ले.
हाँ, इस पे आ नहीं रहा है.
मैम स्लाइड शो ऑन कर लीजिए.
नहीं, स्लाइड शो ऑन है या मुझे दिखाना?
नहीं मैम, स्लाइड शो नहीं आ रहा है इसमें.
It's not.
Dr. Sudhi, your voice is not clear.
नहीं, इसको ठीक करो. Stop sharing.
सभी जितने व्यूअर्स हैं वो प्लीज अपना माइक ऑफ कर ले, तो उससे वॉइस क्वालिटी इंप्रूव कर जाएगी. मैं भी अपना माइक में ऑफ में मोड में ही रखता हूँ.
Click to return to the video call. Okay, सर प्लीज मैंने इसको बंद करके दोबारा किया है. इसको चेक करो. Undo. Your entire screen. कैसे करना है?
वही पे शेयर वाले
शेयर. ओके सर, अभी आ रहा है क्या?
ये लेट शिफ्ट.
इसमें देखो.
हाँ ठीक है, आप इसी पे मूव करते हैं, कोई दिक्कत नहीं.
सर
अगर फुल स्क्रीन हो जाए तो बेहतर है. हाँ, यस, नॉट बेटर.
सर, इज इट कमिंग नाउ? मेरा स्क्रीन.
या ठीक है.
ओके, बट इट इज स्टिल नॉट शोइंग ना, वैसा वो चीज नहीं आ रहा, रोटेट नहीं कर रहा.
लेट है.
नहीं, लेट नहीं. ओके, अब आया. ठीक है, ठीक है. ओके सर, यहाँ पे थोड़ा सा लैग टाइम है. आई एम सॉरी, बट आई थिंक अभी आ रहा है. हमारा ऑडियो जल्दी पहुंच रहा है, वीडियो थोड़ा सा लेट है। हाँ, ओके, नाउ आई स्टार्ट सर। ये स्टोरी है एक 41 ईयर ओल्ड फीमेल की, जिसको बायलेटरल रिकरेंट नेफ्रोलिथियासिस थी। बार बार किडनी में स्टोन्स बन रहे थे फॉर पास्ट 13 ईयर्स। 2009 से उनको ये प्रॉब्लम थी। She underwent repeated lithotripsies and PCNLs. So she was having multiple interventions, and she was considered an endemic stone former and never worked up for recurrent nephrolithiasis. So, but this was not her main complaint. Her main complaint was the multinodular goiter, which she noticed around in 2012, which was initially gradually progressive, but for past 1 year, it showed a rapid progression with pain and choking sensation. So apart from choking, she had difficulty in deglutition, more for solids, and respiratory distress. So please confirm whether this audio and video are matching or not.
Yes.
Yes, ma'am, it is matching.
Fine. So before going further, I would like you to listen her story from her own mouth कि ये कैसे बनते हैं, इस तरह के पेशेंट कैसे प्रेजेंट करते हैं. So for all those, please listen.
तो हमें जो पता चला था 2009 के आसपास, 9 या 10 के आसपास था, इनको बहुत तेज पेन हुआ था। जब दिखाया अल्ट्रासाउंड वो सब कराया तो उसमें स्टोन आया था। उन्होंने वो केवीपी किया, लेफ्ट में थी शायद, वो धीरे धीरे बढ़ती रही। हमने फिर उसको लेजर से तोड़वाया। ये 2009 के आसपास की बात फिर हो गई थी। कुछ दिन के बाद फिर हमने टेस्ट कराया कि देख लेते हैं, फिर पेन हुआ, देखा उसमें फिर से स्टोन बन गई। हाँ, पानी वानी पिया लेकिन नहीं निकली, वो फिर बढ़ने लगी। तो फिर एक बार और कराया था लेजर से ही, वो 6-7 महीने बाद ही कराया। फिर उसके बाद ये फिर जब बढ़ी तो फिर शायद दोनों में थी। हाँ, फिर ये दोनों में हो गई तो हमने खूब दवाई लेकिन नहीं हुआ। फिर भी पीसीएनएल से वो निकाल दी। ये है 2010 की, उन्होंने लेफ्ट साइड, हाँ वो उन्होंने कंप्लीट। फिर 2-3 साल तक कुछ नहीं हुआ। 2-3 तो इसकी दवाइयों से भी निकली। कांटे वाली थी, प्रेशर जो है रुक गया था, टॉयलेट नहीं आया। मैंने फिर रात भर परेशान, सुबह मुझे लेकर गए, वो निकल गई, छोटी थी। ये तो खैर अभी ये तो 2019 या 20 के आसपास की बात, और स्टेंट डाल दिया था, ठीक रहा। फिर वो धीरे धीरे छोटी छोटी बननी शुरू हो गई। वो कह रही ये आपको बनती रहेंगी, बस पानी वानी खूब पीना है और दवाइयाँ खानी है। इस हाँ,
तो आपने पूछा नहीं कि
पूछा था क्या? उन्होंने यही बोला कि किसी की टेंडेंसी हो जाती है, बनती रहती है। और फिर वो कह रहे कि ये जैसे अपना वेस्टर्न यूपी है, इधर स्टोन की प्रॉब्लम ज्यादा होती है, पहाड़ों पे जैसे लंग्स वगैरह की होती है, तो ये इस तरफ का एरिया जो है यहाँ स्टोन की प्रॉब्लम ज्यादा रहती है। वैसे किसी ने इसके ऊपर ज्यादा सोचा ही नहीं कि ये इसका कुछ करा दिया जाए या कुछ इसके कोई टेस्ट वगैरह करा जाए। नहीं पता था इस बारे में कि जैसे डॉक्टर ने बोला चलते हैं कि अब करा लिया है, अब ठीक हो जाएंगे, अब फिर दोबारा से भी है, फिर वही चीजें। तो मैं इस चीज से थोड़ा कि बार मुझे क्यों बनती है। तो वो 35 mm की हो गई थी। हाँ, ये राइट में हुआ, 30-35 mm की हो गई थी। इससे मेरे ब्लड आने वाला था यूरिन से, उसमें 35 mm की। उसमें यूटर में फाइब्रॉइड्स थे। हाँ, ऐसा लगता था कि जैसे कि ये आपस में कट कर रही है। नहीं, ये 1 साल हो गया।
इससे पहले आप बिल्कुल ठीक थी जी, कभी हड्डियों की शिकायत नहीं है, सिर्फ किडनी की शिकायत, हड्डियों की शिकायत।
हाँ, यूरिक एसिड भी मैंने इनका इसीलिए कई बार कराया, लेकिन उसमें भी कुछ नहीं आता। हाँ, पेन होता था, पूरी बॉडी गिरी रहती थी, मैं उठ ही नहीं पाती, मेरा मन नहीं करता था किसी का। पेन रहता था, को रात में ना बेचैनी हो जाती थी, नींद नहीं आती थी, क्योंकि सांस घुटता था। और इसके चक्कर में मैं भी पूरी रात जागता था, क्योंकि इनको नींद नहीं आती थी, सांस घुटता था, ये बैठ जाती थी, मुझे बेचैनी हो रही। मुझे लगता था अब इनको लेके भागना पड़ेगा हॉस्पिटल, क्योंकि अल्टीमेटली हॉस्पिटल जाने से कुछ होना नहीं था। वो क्या करें, ऑक्सीजन लगा देंगे, उससे कुछ नहीं होना, वो तो यहाँ से बंद हो रहा। अब वो ये डिले बोले नहीं, मुझे ये ऑपरेशन नहीं कराना, मैं बचूंगी नहीं। लगता था कि मैं नहीं, राजी नहीं किया। लेकिन जब मेरा ऑपरेशन हो गया
और फिर मुझे सब चीज़ें मेरी सही हो गई। मैं विश्वास ही नहीं कर पाई, कुछ दिन तक तो मुझे लगा ही नहीं कि मैं ठीक हो गई हूँ। मैंने कहा ये सब चीज़ें कैसे हो रही है, मुझे सांस बहुत अच्छे से आ रहा है, मैं सब चीज़ें मतलब एक स्ट्रेस जो था वो दिमाग में से निकल गया है।
पर ये था ना, जब ये आपसे मिली ना, ये जब हम पहली बार आपसे आए, दूसरी बार जब आपसे मिले, तो इनको तब जाके ये राजी हुई थी ऑपरेट के लिए, बोले नहीं वो
ओके। सो
तो
ये जो
हमें
हिस्ट्री
जो
है,
पता चला था
ये जो this history, I am certain that many of the physicians, surgeons, they might have encountered patient with almost the similar history, especially the urologist. So we'll discuss about it in detail. The thing is, now we move on. On clinical examination, everything was unremarkable, except that she had a multinodular goiter which was with partial restricted mobility. So I request Dr. Annie to please describe her neck images.
Good afternoon, ma'am, and all the senior faculty members. So the patient was referred to our radiology department for investigation, where we did a contrast CT scan of the leg. These are the X-ray images of the neck, where we can see both the lobes of the thyroid gland, including the isthmus, are bulky and enlarged. They are far more enlarged, जैसा नॉर्मल होता है उससे ये बहुत enlarged है. We can also see multiple hypo-enhancing nodules as compared to the enhancing thyroid gland. Since the thyroid gland is very vascular, it is enhancing more as compared to the nodules. And जो हमारा center image है, here we can see the enlarged thyroid glands are also causing compression over the trachea, and there is mild extension to the retrotracheal region also in the prevertebral region towards right side, which may be the main cause of her choking sensation as complained by the patient. These are the total images of the same patient. Here we can see both the lobes of standard markedly enlarged with multiple variable sizes of these colloidal. And also in the central and secondary margin, we can see there is another nodular bulging region, mainly from the inferior pole of the right thyroid gland. This can be either an large nodule with an component or a remote possibility of inferior parathyroid also cannot be, but there was no distinct capsules in this. In this enlarged Excel image also, we can see the thyroid gland mainly on the right side, which is extending to the retrotracheal region, and it is compressing the trachea both from the side and posterior. Given in the SAD images, if we enlarge the SAD images, we can see there is significant compression of the trachea from the posterior aspect. Ma'am, ultrasound abdomen was also there of the patient, but the images are not available right now. So the patient had stones on both sides. She came for ultrasound abdomen in April. So there were stones in both the kidneys. Otherwise, the abdomen was normal. And this is the chest X-ray, which was normal.
So the patient was sent for FNAC after that, and I request Dr. Bhavna to tell about the FNAC findings.
Good afternoon, everyone. This was thyroid FNAC that we did, and here we can see some small, round, regular, uniform follicular epithelial cells, the blue ones. Then there are smaller RBCs, and background we can see. My previous slide, please. Background we can see thin colloid. The purple background is of thin colloid, so it was reported as colloid goiter.
Since the patient had compressive symptoms, restricted mobility, recent increase in size, so we found it useful that if we can have an upper tracheobronchial endoscopy, and when we did, we found that the trachea was compressed from side to side and anteroposteriorly, and this is just for our interest. Okay. So since the patient had another history of recurrent nephrolithiasis, this was different from her primary presentation, but still out of interest. Apart from the thyroid profile, which was normal, we asked for a ionized calcium. Though her ionized calcium, you can see, is within normal limit, but and creatinine and other things were normal, but to our surprise, her parathyroid was significantly elevated, 422. It was more than 5 times the normal, so which was unusually raised compared to the ionized calcium, which was high normal. uh, uh, which confirmed the biochemical diagnosis of primary hyper-parathyroidism. We also had her BMD, bone mineral density assessment, which confirmed that she had osteoporosis in her cortical bones, in her wrist joint, compared to in her cancellous bones like spine and the hip. So after biochemical diagnosis, we requested for maybe scan, a parathyroid scan, and I request Dr. Reena to describe the images.
This is maybe parathyroid scan. This is done as a pre-surgical tool with this parathyroid adenoma, so that surgery will be achievable with minimal invasion. And this is done with intravenous injection of technetium maybe, and we are just looking at uptake in the thyroid and parathyroid region. Early phase, you can see both the thyroid glands, both the thyroid lobes are visual with inhomogeneous distribution. It was seen in 1 hour image. 1 hour image, you can see there is again there is uptake seen in both the lobe of thyroid gland, though more pronounced in right lobe. With further delayed images at 2 hours, the radio tracer was washed out from thyroid gland almost. But one focus of activity remained right lobe inferiorly. This was considered to be a parathyroid adenoma because this pathology is like if focus is intense on delayed images with complete washout from thyroid, this will go in favor of parathyroid adenoma. So this is all about the parathyroid scan.
So, following the biochemical diagnosis and with 2 localization studies confirming the lesion in the right inferior pole of the thyroid, our clinical diagnosis was that the patient has a euthyroid compressive multinodular goiter with recurrent nephrolithiasis, with metabolic bone disease, cause primary hyperparathyroidism, cause right inferior parathyroid tumor. So anyhow, the patient was planned for total thyroidectomy. We explored both the sides of the neck, but we did not find any definitive parathyroid lesion. So we looked for all the carotid sheath and other important regions where we usually find the parathyroid and look for it. Ultimately, when we grossed, we find one subtle lesion at the inferior pole of the right lobe of the thyroid. And again, I request Dr. Bhavna to please describe the pathology and the gross and the pathology images.
So this was formerly fixed specimen that we received. In the left image, we can see the larger right lobe and the smaller left lobe. Also, the red arrow, which is there in the right lobe, it was where madam had marked a thread where we could possibly find the parathyroid. Now, when we serially sliced this tissue, then as we can see in the right image, it was on the right lobe inferior aspect where the thread was, and we see this white tissue which was parathyroid tissue, and it is well separated from the thyroid by a very thin capsule which is appreciable in the upper image. Now we can see in this, the parathyroid adenoma involves only one of the glands, while hyperplasia generally involves partially or completely all the glands. In our case, we found only one parathyroid gland to be enlarged. So this is normal parathyroid histology. On the left, we can see the low power or scanner view. Here, the blue and pink areas that we are seeing, this is the parathyroid parenchyma. And the white areas that we are seeing is the stromal fat. So normally parathyroid has roughly 35% of stromal fat, and in the right side we see the hyper view. where we can see the uniform round cells with clear cytoplasm. These are chief cells. In the lower side, we can see cells with pink cytoplasm, which is pink granular eosinophil. Those are the oncocytes. Next slide. So this is our patient histopathology. Here on the left side, we are seeing large colloid-filled follicles. They're lined by flat follicular epithelial cells. Then there is this pink band, which is the fibrous capsule. Now on the right is the parathyroid adenoma. It is different from the normal parathyroid in absence of fat cells, and also there are abundance of blood-filled thin capillaries. So it is very vascular. Next slide. This is hyper view of our case. Here we can see that the cells are very small, round, regular, uniform, and also there are some small capillaries. Now these cells, they're not showing any atypia. There is no mitosis, no necrosis. So we called it parathyroid adenoma. Next slide.
So since here I would like to emphasize that as I told that during surgery I did not find any definitive discrete parathyroid like lesion. So one secret I am telling you that I did the grossing as a surgeon with the pathologist. So we both did the grossing together so that we don't miss any parathyroid like lesion in our grossing, because grossing is very important part of any histopathology. So this should be emphasized that a close association of a surgeon with the pathologist is a key to success. So fortunately, the serum calcium dropped following surgery within 48 hours to 7.9, and her parathyroid also came to 8.4, that is within normal range. So this confirmed that she had a biochemical cure following surgery. Okay, so why we put this case here? Important point is that this patient missed the diagnosis of parathyroid hyperparathyroidism for past 13 years. She was having the problem, but she was missed. So through this forum, we try to find out, to understand the basic pathophysiology, workup and management of recurrent stone formation, the status of parathyroid in that workup. So we just wanted to understand from the urologist point of view regarding the workup and management of such cases. Then also we want to make them understand the basic understanding of primary hyperparathyroidism, because once it was considered as very rare type of disease, but it is not the case. It is present, but it is a different thing that we don't identify such patient. What is the impact of hyperparathyroidism on kidneys, especially if it is untreated, and the consequences of neglected parathyroid tumors? And now I request our colleague Dr. Vikas Giri to present his aspect.
Dr. Sudhi.
Thank you, Dr. Sudhi.
Yes,
Dr. Vimal, just can I add 2 points here?
Yes, sir. Please.
There are 2 theoretical aspects in the discussion which we had just now related to your case. One is related to diagnosis of the differentiation between adenoma and carcinoma. So, Dr. Bhavna described very well. At least we are not used to see these slides. We are being just informed about what is there in the slides. Otherwise, we don't know much about pathology. But theoretically, what we say that endocrine malignancies, they are not diagnosed on the basis of cellular atypia. They are diagnosed on the basis of 2 factors. One is vascular invasion, and second is capsular invasion. Be it anywhere in thyroid, parathyroid, or other endocrine glands. So vascular invasion and capsular invasion are 2 criteria for endocrine malignancies for which we need biopsy rather than just FNC. So, Dr. Bhavna, please correct me wherever I am wrong.
No, sir, that's absolutely correct. So in this case, we did not find any invasion.
Yes. I was trying to look over those areas. The second thing which usually happens where we people are called in regarding any post-operative care of these patients, that there is a sudden drop, as Dr. Sudhi has shown, that actually from 11.5 or 12, whatever you said earlier, it dropped to 8.9 calcium level. So, with prolonged hyperparathyroidism, bones are actually demineralized. So what we call hungry bone syndrome. So they are devoid of calcium. As soon as the thyroid is removed, they start taking calcium very vigorously, and that leads to sudden drop in calcium level. And we should be proactively aware of this fact, and we should be very active in supplementing calcium along with vitamin D in movies. So this is what we discuss here. Please.
अभी जरा पूछे कितनी है
Dr. Pradeep, Dr. Pradeep, Dr. Pradeep Gupta, Dr. Pradeep Gupta, आपसे रिक्वेस्ट है प्लीज अपना माइक ऑफ कर ले। अच्छा, जो एडमिन है करते हैं उसको डॉक्टर प्रदीप गुप्ता का माइक ऑफ करवा दें। डॉक्टर बोलिए जिससे जो एडमिन है।
सर आप क्लोज कर सकते हैं शायद उनका माइक। यू टेल कौन करेगा सर?
खुला करने की दवा आती है तो मैं शाम बोला।
ओके सर हम कर सकते हैं।
बने तो 10 क्रांति ले लियो।
अगर किसी पर मोबाइल नंबर है तो प्लीज फोन करके बोल सकते हैं। मेरे ख्याल से बहुत ज्यादा सुन कर है।
तो कैसा these are minor glitches जनरल में सेट हो जनरल में सेट क्या मिलेगा
sir is muted fine
okay thank you
okay actually I'm also very new to this technology. I'm very sorry, but like with repeated use I will become more perfect and expert in all these
actually Zoom is a better platform for presentation,
yeah,
but Zoom has limited its limit to 30 or 45 minutes I think.
But anyhow, with Google is also a good platform. But the thing is that we are not that much used. Maybe with time,
yes.
I will try to be more.
Please start the slideshow.
Fine.
And please excuse me for actually back there in hospital Wi-Fi was not working, so I had to present it from my car on mobile network.
Okay.
So please if.
So are you able to see the slide?
Yes.
Yeah. So
start
is it moving?
Slideshow.
Is it moving?
Yes. It's
fine.
moving.
Now you can start. Thank you.
Okay. Thank you, Dr. Sudhi. And now what will be our objectives today? So there will be introduction and basics of basics and pathophysiology of renal stone formation. What is recurrent urolithiasis or high-risk urolithiasis? Complications of recurrent and high-risk stone disease. Causes. What are the various causes of recurrent high urolithiasis? And basic workup and basic management of recurrent or high-risk urolithiasis. Next slide, please. So when it comes to basics, we all have read in chemistry that for a crystal to form, when a solution forms, then we mix solvent with solute, and we keep adding solute on in solution. The solution becomes saturated. If we add more solute, the solution will become supersaturated. In supersaturated solution, anytime crystallization can happen. Take urine as a supersaturated solution. Urine is always supersaturated. Urine has urine is a mixture of various solutes. Some are inhibitors of crystallization and some are promoters of crystallization. Please, next slide. So, substances written on the right or left are promoting factors for crystallization, such as calcium, sodium, oxalate, urate, cysteine, low urinary pH, low urine flow, that is dehydration. Bacterial product and time absorbed protein comes under both segments. And there are inhibiting factors. Most important are inorganic factors like citrate, magnesium, pyrophosphate, and there are various organic factors. So it is very important to understand how stone forms. Uh, it is excess of promoting factors of crystallization that can create stone formation, or lack of inhibiting factors. So if inhibiting factors are less, stone will form, and promoting factors are more, stone will form. So there is urinary pathogen. Basic steps of urinary stone formation are supersaturation of urine. Then there can be nucleation. Nucleation can be of two types, homogeneous and heterogeneous. Heterogeneous, in which the basic nuclei of stone is of different salt, like uric acid, and over that some other salt deposition can occur, like calcium oxalate. And homogeneous is basically both nuclei and over the stone formation are same. After that, crystal growth occurs, and there is crystal aggregation. Then finally, complete stone formation. So in these various steps, inhibitors work to, and any of this step, if inhibitors can inhibit any of these steps, stone cannot be formed. So next slide, please. This is totally different kind of stones, like infection stone, also called as true stone, and commonly other phosphate stones also. So these stones happen in cases of infection with urea splitting organisms, like Proteus and Klebsiella, most commonly. And high urinary pH and bacterial components are also required for formation of these stones, and stool-white phosphate are most common. So next slide, please. Now, what is recurrent urolithiasis? Detection of stones after successful surgical removal or spontaneous passage is defined as recurrence. The risk of recurrence of urinary stones is about 50% for lifetime and 10% every year. And in a recent review of first-time stone former calculated a recurrence rate of 26% in 5 years' time. About 50% of recurrent stone formers just have one lifetime recurrence. And highly recurrent disease was observed in slightly more than 10% of patients. So next slide, please. Now, what are the risk groups? The risk state of stone formers is of particular interest because it defines the probability of recurrence or regrowth, risk of CKD, ESRD, risk of mineral or bone disease, and these high-risk patients should be administered with pharmacological treatment. Now, stone type and disease severity determine lower high-risk stone formers, and they need comprehensive metabolic analysis and should be offered pharmacological treatment. Next slide. Now, what are the complications of recurrent stone disease? These patients may require repeated surgical intervention, and when there is repeated surgical intervention, procedure-related complication can happen. There can be recurrent infection, recurrent pyelonephritis. Chronic pyelonephritis can also occur. Pyelonephrosis can happen. Chronic kidney disease and end-stage renal disease can also occur in these patients. And we should not forget about financial and immense financial and psychological burden of recurrent stone disease. So, what are these high-risk stone formers? There are some general factors which the risk of CKD or recurrent, like early onset, especially in children and teenagers, familial stone formation, short time since last stone episode, brushite, calcium phosphate, which is a type of calcium phosphate stone, brushite containing stones, uric acid or urate containing stones, infection stone, and solitary kidney. Next slide, please. Now, diseases associated with stone formations are most important, which we are discussing here is hyper-parathyroidism, metabolic syndrome, polycystic kidney disease. There are some gastrointestinal disease which can increase oxalate absorption, and bariatric surgery. Increased level of vitamin D, either endogenous or exogenous, due to endogenous or exogenous factors, sarcoidosis, spinal cord injury, and urogenic bladder due to stresses of urine. Next slide, please. There are some genetically related diseases like cystinuria, primary Leishman syndrome, and distal RTA. Next slide, please. Now, there are some anatomical anomalies associated with stone, and these anatomical anomalies mostly cause stone due to stasis. And there are some environmental factors and professional factors like working in high ambient temperature and exposure to chronic lead and cadmium. Next slide. Hello.
Yeah, is it changed?
Am I audible?
Hi, you are audible. You are very well audible. Are you able to see
Yes,
the
yes.
slide? Yeah.
Yes. Now there are some drugs which can cause stones. Uh, some drugs can actively crystallize in the urine and form stones themselves. And there are some drugs which can change the urinary composition by changing concentration of promoting factors or inhibiting factors. So they cause stone by that mechanism. Next slide. Now there are some stone formers which are at high risk of metabolic bone disease and calcium renal stones, which include distal RTA, medullary sponge kidney, primary hyperparathyroidism, malabsorptive syndromes, fasting hypercalciuria, and genetic disorders. Next slide. Now, some words about primary hyperparathyroidism. That is also a cause of resorptive hypercalciuria. So this is a cause of nephrolithiasis in about 5% of cases. Calcium nephrolithiasis with elevated serum calcium as well as other factors including a high percentage of calcium phosphate stones. So this is very important, calcium phosphate stones and high urinary calcium levels. These all factors should trigger suspicion of primary hyperparathyroidism. Most patients with PHPD demonstrate hypercalcemia with hypercalciuria. Normal serum calcium level with high serum PTH may also be seen. And PTH also increases excretion of bicarbonate and phosphorus in proximal renal tubule, resulting in phosphaturia and mild hypochloremic acidosis. It can also lead to medullary nephrocalcinosis, decreased renal function, acquired distal renal tubular acidosis. Now, next slide. If a patient is having normal serum calcium and high parathyroid, then thiazide challenge can be given to that patient. Although it is a risky procedure because it can raise serum calcium to dangerous levels, so it should be performed with caution. And in this test, thiazide is administered, and decrease in urinary excretion is observed after and rise in serum calcium is observed. So even after if hypercalcemia occurs and parathyroid is not suppressed, then it raises suspicion of hyperparathyroidism. Now workup for high risk and recurrent stone formers. Now what are the parts of workup? First is history, second is imaging, blood and serum investigation, 24-hour urinary metabolic profile, and stone analysis. These are very integral parts of any recurrent stone former, especially 24-hour metabolic profile and stone analysis. Next slide, please. So what we look in history, any underlying predisposing condition which I described before. Medications such as calcium, vitamin C, vitamin D, acetazolamide, steroid, or any other stone forming and urine altering medication. Dietary excesses like high protein diet or high calcium diet, inadequate fluid intake, excessive fluid losses. Now, imaging such as CT, USG, or MRI for anatomical factors and for whenever surgical intervention is required. Multi-channel bone scan, basic metabolic panel which look for sodium, potassium, chloride, blood urine nitrogen, creatinine, serum calcium, intact parathyroid hormone is a part, and uric acid and C-reactive protein. Now next slide. 24-hour urinary metabolic testing should be done on normal day-to-day diet and normal hydration, which patient usually have. There should be no special diet and no special hydration conditions like excessive fluid intake, etc. And patient should ideally be stone-free for at least 20 days. Now, next slide, ma'am. Follow-up we can discuss later. Now, what we look in 24-hour urinary profile, most commonly assayed urinary constants are oxalate, calcium oxalate citrate, total volume of urine in 24 hours, sodium, magnesium, potassium, pH of the urine, uric acid, and sulfate concentration. This table shows the normal values of various constituent of urine. Next slide, please. Stone analysis. Stone analysis can be done by infrared spectrometry or X-ray crystallography. This table shows most commonly found stone composition. Most commonly found composition is calcium oxalate, which occurs in 60%. Hydroxyapatite is a type of calcium phosphate stone, 20% of the cases. Brushite stone are 2%. And rest of the non-calcium containing stone. Now, how we interpret the preventive measures like fluid intake, drinking advice to 2.5 to 3 liters fluid per day, circadian drinking that we divide fluid intake over the daytime and not in binge drinking type sort of scenario like some patient drink 2 liters, 3 liters in single time and they don't drink afterwards. So that is not correct. They should divide their 2 to 3 liters. And neutral pH beverages. This should produce around 2 to 2.5 liter urine per day. And then 1-0-1-0. Some nutrition advices like balanced diet, rich in vegetable and fibers, normal calcium content. Calcium should not be restricted. Limited salt content. Salt, we should advise patients to reduce salt content in their diet. Limited animal protein and some lifestyle modifications such as maintain a healthy weight, adequate physical activity, and balancing of excessive fluid loss in case of like patients of diarrhea and other malabsorption syndromes. So we should balance with those with fluid intake also. Now, next slide. Now this is the workup of calcium phosphate stone because we are discussing hyperparathyroidism and phosphate stones are a characteristic, one of the characteristic of hyperparathyroidism. So we will start with calcium phosphate stones. Now if we analyze stone and it comes out to be a phosphate stone, then it can be of apatite or brushite type. So basic evaluation is done. Then if we find hypercalciuria, then hydrochlorothiazide can be added. If urinary pH is more than, if this is alkaline urine, urine is strong urine, then we should exclude RTA, we should exclude UTI. And we can adjust the urinary pH by providing L-methionine to the patient. And also, if there is elevated serum calcium, then we should exclude hyperparathyroidism in case of hepatitis stone. Now, brushite stone should straight away prompt the investigation for hyperparathyroidism, and we should also exclude crystal RTA. If there is hypercalciuria more than 8, then hydrochlorothiazide should be prescribed to the patient. Next slide, ma'am. Now, if we find calcium oxalate stone in a stone analysis, then we should look for the results of 24-hour urine panel. And there are many things for calciuria. If we find hypercalciuria and calcium oxalate stone, then we should look for blood panel. And if in blood panel we can find hypercalcemia, then it raises suspicion of hyperparathyroidism, granulomatous diseases such as symbiosis, vitamin C excess, malignancy. Some malignancies can produce parathyroid-related peptide and can produce similar symptoms. And hyperthyroidism can also produce calcium oxalate stones by increasing bone turnover. In hypercalciuric cases, we can find normocalcemia. In normocalcemia, uh, there can be idiopathic hypercalciuria, which is the commonest cause of hypercalciuria, and followed by glomerular diseases and vitamin D excess. And if we find normal calcemia with metabolic bone disease, this should raise suspicion of distal RTA. There are magnitude of other abnormalities also, but I think these abnormalities are out of scope of our discussion here today. Like calciuria and calcium oxalate stone, we should measure the hypercalciuria. If it is more than 8, so we can add hydrochlorothiazide to reduce the urinary excretion of calcium. And if it is less than 8, then alkaline citrate like potassium citrate can suffice. And there are other causes. Citrate also added, and in various other causes we can add different other things also. So I think if audience are interested, then we can go ahead.
So thank you very much, Dr. Vikas, and for for such an elaborate discussion and telling us about how exactly you work out a patient.
Actually, there are many more types of stone, and there's just I think that is not comes under the scope of our discussion here today.
That's why we put our learning objective so that we can focus our discussion for some.
So I covered only the basics and related topics only.
Thank you very much. So,
Dr. Sudhi,
yes, sir.
Let me summarize few important points out of what has been discussed so
yes,
far.
Sir.
Number one, regarding management, I am directly going to management and preventive aspects which have been dealt in very well. Now, there are few things which should be highlighted, though it has been covered. One thing is we always focus about increasing water intake in a patient who is a recurrent stone former. But the definition of increasing water intake may vary. So, focus should be, rather than going for measuring water intake, focus should be on measuring urinary output, as has been dealt very well, that output should be maintained in the range of 2 liters plus, at least 2 or 2.5 liters per day. So, if patient is passing more than 2 liters of urine, its water intake is adequate. Otherwise, we need to increase water intake till urine output becomes more than 2 liters per day. So, we should focus on urinary output rather than water intake. Secondly, as has been discussed again in detail about calcium intake, there are two things. That calcium intake which is included in normal diet, it should not be restricted. Even if I talk about myself, I used to say to my brother who is a recurrent stone former that तुम milk बहुत लेते हो, milk कम करो तुम्हारे इसीलिए stone बनते हैं. Till the time I realized that dietary calcium is not a big factor in increasing hypercalciuria. So, dietary calcium intake should not be restricted, otherwise chances of metabolic bone disease increases too much. So it is the calcium.
There is another factor about dietary calcium, because if we reduce the dietary calcium, actually how oxalate excretion occurs.
Yes.
Calcium binds with oxalate in gut and helps oxalate excretion into our feces. So if we reduce calcium from our diet, there will be more available oxalate for absorption, and calcium oxalate stone formation will increase. This will count. This is this is counterproductive. So calcium should not be restricted, and it helps oxalate excretion in our gut.
So calcium actually interferes or rather helps in four measures. Number one, it reduces oxalate absorption from intestine. Number two, it suppresses, if the system is maintained, then it suppresses parathyroid hormone secretion, prevents secondary hyperparathyroidism. Thirdly, calcium is important in reducing chances of metabolic bone disease, which is otherwise pretty common in patients with recurrent stone formation. So, calcium intake in dietary measures should not be restricted. Yes, calcium supplementation should be avoided. Regarding, as we are talking about complications, metabolic bone disease is a frequent concomitant factor with recurrent stone former. The second thing which should not be missed, that patients with recurrent stone formers are at risk of having coronary artery disease. Metabolic syndrome as has been highlighted in your presentation. So metabolic syndrome is a concomitant factor with recurrent stone former. Chances of hyperuricemia, hypertension, metabolic syndrome, diabetes, and coronary artery disease all increases in these patients. Thirdly, the thing which you have told in the end, vitamin C is metabolized in the body and produces oxalate, and that oxalate increases chances of stone formation once it passes through the kidney. So, vitamin C level should not be too much.
Especially in last 2 years, there is a pandemic of COVID pandemic. Just people were taking vitamin C like they are taking food. So that's very important, because excess of vitamin C can increase oxalate stone formation.
Now the fourth aspect which I would like to highlight, it has been dealt very well, that more than calcium we need to emphasize about sodium intake, because sodium, it increases calcium excretion in the urine. So if we restrict sodium, then hypercalciuria reduces. So we need to emphasize that plenty of fluid to pass 2 liters of urine, low sodium diet to reduce hypercalciuria, normal calcium intake as per the daily requirement, and no added vitamin C would be better. So these things should be emphasized, which are otherwise very often overlooked in these patients.
And there is one more point, that the sodium chloride can provide nidus nuclei, heterogeneous nucleation for calcium oxalate stones. So this is also a point for reduction for salt intake.
Yes. And at last, about the management aspect, as you have dealt, that thyroid diuretics, they are good. There are two types of diuretics. One is loop diuretic furosemide. That actually increases hypercalciuria. So whenever these patients are requiring diuretics, we should avoid using loop diuretics, because it precipitates, it increases chances of stone formation. We should use thyroid diuretics, and more so chlorothalidone, which otherwise we uses less sparingly. So chlorothalidone, because of longer half-life, is better in these cases, and it should be in adequate amounts, 25 to 50 milligram per day, which we don't use in our routine practice. We get satisfied with 12.5 milligram or so. So thyroid diuretics with potassium citrate solution, it helps in reducing chances of recurrent nephrolithiasis. That's what I wanted to just.
But one point, sir, that thyroid diuretics are contraindicated in cases of hyperparathyroidism. That should also be remembered.
Because
they can cause dangerous hypercalcemia. So they are contraindicated for those patients.
Our focus shifts towards management of hyperparathyroidism.
In those patients, in those patients, curative treatment is only surgery.
Yes.
Meanwhile, when patient is waiting for surgery or if patient cannot undergo surgery, citrates and mainly increasing output of urine. These are the two main factors which can prevent some degree of stone formation in hyperparathyroidism.
Again, one more factor I would like to repeat what you have said. That's among serum calcium and urinary calcium. We think serum calcium is more important, but in patients with recurrent stone formation, it is the urinary calcium level that is more important here. So we need to rule out hypercalciuria. If patient with hyperparathyroidism might be having normal serum calcium level, but if there is hypercalciuria, it will increase the chances of nephrolithiasis. So very well described these factors. I just wanted to repeat these things so that we should remember. Even I should remember it again and again. Thank you.
Okay, I'm so privileged with this brief discussion only. I have got an opportunity to learn so many new things which I was either not knowing or knowing very briefly. Now it is being discussed in such an elaborate way. And thank you very much, sir. So, friends, there is one very important quote I still remember from my professor in medicine, Dr. R.C. Ahuja, when I was an undergraduate student, that treatment of any patient is never an issue. The most important aspect which as a physician, as a clinician, we must learn is to diagnose. So diagnosis making takes a toll of us. So here is what we want to improve ourselves. So parathyroid and calcium are very closely interrelated. So before going into the detail of primary hyperparathyroidism and its effect on kidney, first for very brief outline of how this parathyroid, vitamin D and all actually works. So friends, our body has a great power of hemostasis. So calcium is also maintained within a normal range with the help of three important hormones. These are parathyroid hormone, vitamin D and calcitonin. So parathyroid hormone and vitamin D, they increases the serum calcium level, and calcitonin helps in decreasing the serum calcium level. So another point we must need to understand that in our body, calcium is present in three important forms. First is the diffusible. It is a freely available calcium that is readily available for any physiological process that is happening in our body. Another is the non-diffusible, but it is readily available when it is required. It is usually protein bound or albumin bound. And third form is the complex calcium, which is not at all readily available. It is something like a bank. So it is deposited in the bones, and whenever it is required, the body takes the calcium from the bones. Sorry. And this tight regulation is being done. The master of this tight regulation is the parathyroid hormone, which is secreted from the parathyroid glands, which are located posterior to the thyroid lobes in the paratracheal position. These are usually 4 in number in 80% of the cases, 2 on the right side superior inferior, 2 on the left side superior and inferior. On microscopic examination, as Dr. Bhavna told, that there are 2 important cells, chief cells and the oxyphil cells. Chief cells, they produce the main hormone, and the oxyphil cells helps in the staining, the characteristic staining. Okay, so what happens? Suppose our usual calcium level is between 9 to 11 or 8.5 to 10. So suppose this calcium level comes down. So it triggers the calcium sensing receptors, which stimulate a cascade of reaction, and the parathyroid hormone is released. Parathyroid hormone, as I said, increases the blood calcium level. On the contrary, suppose the blood calcium level is very high, then these extra calcium molecules, they again stimulate the calcium sensing receptors, and which stops this cascade of reaction, which further stop the parathyroid hormone secretion. So there is a negative feedback, which is important for a hemostasis of the body. So how this parathyroid hormone increases the blood calcium level? Through 3 important processes. First, it causes the bone resorption. Second, it causes the reabsorption of calcium from the renal tubules, and also it stimulates the vitamin D synthesis, and along with vitamin D, it helps in the calcium and the phosphate absorption from the intestine. In kidney, it causes calcium absorption and phosphate excretion. So this point is very important, that the phosphate is excreted and calcium is absorbed, whereas in intestine both calcium and phosphates are absorbed. Why it is important, that we'll discuss. So what is hyper-parathyroidism? Whenever this normal feedback phenomena is lost due to excessive secretion of parathyroid hormone, then we term it as hyperparathyroidism. So it is of three important types: primary hyperparathyroidism, secondary and tertiary. So in a very simplified way, if I can describe these different types, in primary hyperparathyroidism, one or more of the parathyroid glands are involved, are affected. In secondary hyperparathyroidism, the parathyroid glands are normal, but there is some external stimulation from outside which stimulates the secretion of parathyroid secretion. And in tertiary hyperparathyroidism, this external stimulation persists for very long time, such that one or more of the parathyroid gland now become autonomous because of this external stimulation. So if the external stimulation is now stopped, suppose the patient has renal transplantation and the external stimulation is stopped, still the patient will keep on secreting the parathyroid hormone. So this is the main difference. Now in primary hyperparathyroidism, these are of three important types. First is adenoma, then there is a tumor formation in the parathyroid gland. Then is hyperplasia. There is no tumor formation, but the glands are hyperplastic. They are diffusely enlarged. Okay. And third is the carcinoma. So they have some malignant features in them. Adenoma also, since there are 4 glands, so it could be a single gland adenoma or it could be multiglandular. So the most common multiglandular is double adenoma that we usually see, but other glands may also be involved. So now we talk about primary hyperparathyroidism, which is our main topic of discussion. So what is this? This is the hypercalcemia and inappropriately raised parathyroid hormone. So this term is very important, inappropriately raised or inappropriately suppressed, because that we will discuss that there are normal calcemic PHPT also. So this already I have told about. This primary hyperparathyroidism, this excessive parathyroid hormone, this not only causes hypercalciuria, but it also affects so many cells, especially the neuronal cells in our body. We know calcium is very much required for neuron excitability. So whenever there is mismatch in the calcium hemostasis, then this neuron excitability comes down. They become slow. You know, even the muscles and the neurons, everything becomes slow. So how does these patient present? How do these patients present to us? The clinical symptoms caused by are either because of hypercalcemia or the parathyroid hormone per se, or the combination of both. So patient have effects due to all this. Like suppose in kidney, so it causes hypercalciuria, nephrolithiasis, nephrocalcinosis, that is diffused calcification of renal parenchyma, renal function may decrease, patient may have polyuria and polydipsia, because their blood is hyper concentrated, their urine is hyper concentrated, so that's why they have polyuria, polydipsia and many other things. So just for an information, this is the nephrocalcinosis. So there is a diffuse parenchymal calcification. These patients have usually calcium phosphate type of stones. Now friends, as already I have told, the parathyroid hormone increases the phosphate excretion, and now the natural action of parathyroid hormone on kidney is the calcium absorption. But in this disease, the parathyroid hormone keeps on leaching the bones, demineralizing the bones so as to elevate the blood calcium level. Body doesn't require this much of calcium. but because the parathyroid hormone is now not listening to the normal body hemostatic mechanism, it is autonomous. So it keeps on demineralizing the bone. This elevated blood calcium level or serum calcium level is filtrated by the kidney. Okay, and since the urine becomes super saturated and these crystals keep on accumulating. So this calcium and phosphate product, the calcium is also high, phosphorus is also high, and then they get the tendency that they combine with each other and they form the calcium phosphate stones. So this is how these patients, they generate the stone formation. Okay, the bones start getting weak and the kidneys start getting the stones. Now come to skeleton. As already told, this parathyroid hormone keeps on leaching or demineralizing the bone. So this effect is more prominent on the cortical bones, like our wrist joints. Okay, so these, when we do the bone mineral density, characteristically the wrist joints are more osteoporotic compared to spine or the hip. Apart from that, these patients may present with fragility fractures, skeletal deformities like osteitis fibrosa cystica. These are few pictures like salt and pepper appearance, because there's a diffuse demineralization. So they have punctate calcification, tapering of distal phalanges, then brown tumors. These brown tumors are most of the time either confused with multiple myeloma or with osteoblastic or osteolytic tumors of the bones. Most of the times these are confused like this. In some other session, we'll try to cover the crippling bone disease due to parathyroid hormones. Okay, so neurological, it is very important. These patients have neurocognitive disorders. So friends, these patients present with fatigue, they have anxiety, poor concentration, irritability, mood disorders, memory loss, cognitive decline, altered mental, everything which is suggestive of depression. Okay, so these are depressed and they don't want to work. They have muscular pain, neurological, they have muscular pain, they have bony pains, they have joint pains, and most of the time we attribute these features to some other or some non-specific problems. Then they have neuromuscular. As already told, this neurotransmission needs calcium. Now this calcium hemostasis is disturbed, so they have muscle weakness and wasting. So interestingly, this parathyroid hormone is not only confined to either kidney or the bones. It has a systemic effect. So important systemic effect is cardiovascular. It is something which may be very interesting or surprising to many of us. These patients have high chances of arterial hypertension. As already said, this PTH and calcium, they have independent effects on all the organs. So it is not either due to calcium or either due to parathyroid hormone. It is usually they have some or the other effect in all the organs. Okay, so they have vascular wall changes, arterial stiffness, arterial hypertension, prediabetes, diabetes, dyslipidemia, arrhythmias. Okay, left ventricular hypertrophy, diastolic dysfunctions. Apart from that, they have coagulation disorders. So friends, you know, coagulation also requires calcium hemostasis. Normal calcium is very much required for that. So these patients, they may present with menorrhagia or some other coagulation symptoms. Fine. GIT is very important. It is one of the most common presentation and most commonly missed, because these patients may present with constipation, indigestion, dyspepsia, not responding to any proton pump inhibitor, anything, nausea and vomiting. Since these symptoms are so vague, we never think about ruling out primary hyperparathyroidism in such cases. It may surprise many of us. You know, primary hyperparathyroidism, the reason is still unknown. People are having research on this aspect, but it has been detected the patient with primary hyperparathyroidism, they have increased risk of cancer formation. So most commonly found cancers associated with PHPT are breast cancer, papillary thyroid cancer, colonic cancers, and many more. So reason I'm also not sure. It could be due to genetic factors or some other factors that we need to look into. Okay.
Ma'am, the reason is APC mutation with which they are associated. The parathyroid adenomas are associated with APC mutations.
That's
So that
very
is
nice
why they have
information,
increased
Bhavna.
propensity
And
to cancers.
I assure you, in some other forum, we will certainly discuss about this aspect also. Okay, so you can see that there is a spectrum of symptoms of hyperthyroidism. Some are hyperparathyroidism, some are specific, some are non-specific. But these all the symptoms are very important. So friends, GI symptoms, as I said, are most common, but they are mostly missed. Okay, neurological symptoms are also second most common, but often missed. Other than that, the patient have nephrolithiasis and bone diseases. In around 50, 1/4 to half of the patients with PHPT, they present with nephrolithiasis, and around 1/3 of patients have skeletal bone disease, and around 10% have crippling bone disease. So friends, in any patient, when we suspect primary hyperparathyroidism, it is always and always biochemically that we need to find out, confirm it. Never we jump directly to the imaging. Okay, so it is a very specific protocol. We don't violate this. When the biochemical diagnosis is confirmed, only that for surgical point of view we localize the lesion. So what the important hormones, what the important chemicals that we see into this biochemical profile. So friends, as I told, there are three important types of PHPT: primary, secondary, and tertiary. And what the list, what I will be telling you, it will rule out almost everything. Okay, so we see the serum calcium, total, and ionized. Ionized is more important, but total also we see. You know, then inorganic phosphorus, because in PHPT phosphorus is low. In secondary hyperparathyroidism, phosphorus is high. Then intact PTH, 25 hydroxy vitamin D, renal function test, 24-hour urinary calcium excretion. So it's so simple, nothing fancy about it. Okay, and it most of the time gives us a clear diagnosis that what we have to do in this patient. So friends, this PHPT is further classified. We can classify, just simplify this entity into clinical and biochemical. So friends, do you know, symptomatic PHPT we often discuss, but do you know there are asymptomatic PHPT also? So how do these patients are diagnosed then? There was a time then we used to think that PHPT is a very rare disease. Why it was rare? Because we never tried to find it out. In developed nation, what happened? They started screening calcium in their other routine test. So in those screening, they find out that this high calcium, the hypercalcemia, level of hypercalcemia is not that infrequent. It is very, very high in general population. So in those patients, when they worked out, they found that their PTH was also inappropriately raised and their calcium was also raised, though they don't have any symptom, but they have this hypercalcemia and hyperparathyroidism. That is why they were labeled as asymptomatic PHPT. That's a very different story. In some other session, we will try to elaborate and understand about it. Fine. Then, biochemically, these patients are either hypercalcemic, hyperparathyroid. So calcium is raised, parathyroid hormone is also raised. This is the typical feature, typical pathognomic of PHPT, which we always expect, but it is not always the case. Sometimes we do get normocalcemic hyperparathyroidism, like in our present case. The calcium ionized was in a high normal range, but the PTH was very high, more than 5 times. So our patient was normocalcemic hyperparathyroid. Then the third entity is hypercalcemic normoparathyroid. So the calcium level is raised, but the PTH is not that much suppressed. Ideally, it should suppress with high calcium, but it is not suppressed. So this is the third entity. So if I summarize again, in classical, calcium is high, PTH is high. In hormonal, calcium is high, but the hormone is normal. And in normocalcemic, calcium is normal, but PTH is high. It's very simple, but it takes a great deal in diagnosing such these last two cases. last two categories, it is very difficult to diagnose and reach a conclusion. Now, we have diagnosed a patient with PHPT. What else? Then we localize. As Dr. Vikas said, the only curative answer of PHPT is surgery. Just remove that offending gland and everything will be fine. So, for that, we localize out of 4 glands, which gland is offending, which gland is causing the problem. For that, we use 2 types of imaging. First is the structural and another is the functional. Structural is a conventional way, like ultrasound, CT scan, MRI. So these are the conventional structural localization. The another one is functional localization, like Dr. Reena told. So we use maybe scan to find out the lesion. So why we need two type of localization studies? Okay. So friends, you know, this parathyroid, especially the superior parathyroid, is very treacherous. These parathyroids can be localized anywhere from the base of the neck, base of the head, skull base to the superior mediastinum or the middle mediastinum also. Anywhere it can lodge. So there are some unusual locations which I am showing you. So this we can identify with the help of these two localization studies. Also, initially, when this structural localization was not there, what we used to do is the bilateral neck exploration. Nowadays, if the two studies are concordant, the structural and the functional, then we can very well go ahead with focused parathyroidectomy without disturbing the other parathyroid glands. It's a different thing that we need intraoperative PTH, which is not readily available everywhere, but at least this much of focused parathyroidectomy also gives around 95-96% of curative rate if done appropriately with endocrine surgeons. Okay, so friends, I guess you understand now the importance of two localization studies in PHPT. Apart from that, what we do is to see the extent of the disease. Okay, so we see the osteoporosis, the amount of osteoporosis in BMD. Also, we look for pancreas, we look for kidneys to see whether there are any stones, nephrocalcinosis, how much benefit will the patient get after the surgery, after the treatment, how much the patient is like permanently jeopardized, everything. Also, we assess the genetic nature. You know, friends, around 1/4 of the patient with PHPT, they may have some genetic association, either MEN1 or MEN2A. Okay, so we'll discuss about that also. Symptomatic PHPT, who will need surgery? Surgery, symptomatic PHPT, all the cases. Asymptomatic PHPT, there are certain criteria. When we will discuss about asymptomatic PHPT in some other case, then we will discuss in detail. Okay, so now treatment. You know, surgery is the mainstay of treatment. In this, we have two modalities. Either we can explore both side of the neck, bilateral neck exploration, look for all the parathyroid and take out the abnormal looking parathyroid. Or there is another approach, focused or unilateral exploration, where with the help of two localization study, preoperatively we decide, okay, this side we have to go. We go on that side, remove the offending gland, look for the other gland if it is if it is easily visible, and we just close it. And we look for IOPTH, or not. If IOPTH is not available, at least the immediate post-operative PTH we see and confirm whether we are our surgery is complete or not. Okay. So friends, now comes the very important part. A patient with PHPT, due to one reason or the other, we miss the patient. We are not able to diagnose. What will happen to that patient? First of all, just think about it. Before we had a sound knowledge of PHPT, what was happening to the patient? Bones, groans, cyclic moans. This was the basic mnemonic of such type of patient. So those patients were having crippling disease, recurrent stones, stone-related renal complications, ultimately death or untimely death due to various other factors. Now, do we see such type of scenario? Relatively rare, especially in those areas where there is a sound knowledge of parathyroid PHPT. Okay, so now that we have a concept of asymptomatic PHPT also, so the patients are detected in a very early phase. But still, now if we, in today's scenario also, if we compare a patient who is managed conservatively, either due to misdiagnosis or due to other reason, or the patient who is treated with surgery, so you can see the overall mortality of the patient who were treated with surgery is more compared to the patient who were treated with conservative treatment. So this is the surgery, this is the conservative treatment. Conservative treatment, the survival is low compared to those who were treated with surgery. And the most common cause of mortality in those patients was cardiovascular. So these patients had cardiovascular mortality due to various reasons which I have already listed. In my whole career, Paul sir may correct me when we will discuss about it. So in my whole career, due to benign endocrine disease, after diabetes, I have seen mortality more common in PHPT. Why? I have seen mortality due to chronic renal failure and related, like one patient died due to dialysis, complication due to dialysis or technical failure or many other things. I have seen mortality due to acute pancreatitis. I have seen mortality due to hypercalcemic crisis or parathyroid crisis. I have seen mortality due to cerebrovascular accidents. I have seen mortality near death due to crippling bone disease. Patient had recurrent respiratory infections. Either the patient was bedridden, so the bedridden, because of prolonged bedridden, she was prone to respiratory infections or some other thrombosis and many other things. So it is a life-risking disease if not treated properly. What are the causes and effects of stones induced renal injury? So like parathyroid, it causes the renal injury due to the stones, as well as it is a direct it has a direct insult on the renal parenchyma, both the aspects. Important is the stones induced renal injury. So these patients, stones is a very good needle for bacteria to lodge. So whenever there is a foreign body like stones in the renal pelvis or anywhere else, so these patients are prone for bacteriuria, pyuria. Sometimes they have frank infection, which may lead to pyelonephritis. Also due to recurrent interventions like lithotripsies, PCNLs, they are, with every intervention they are prone for injuries and infections. Then if the stone is impacted somewhere in the pelvic system, then hydroureteronephrosis, nephrocalcinosis, hematuria, so leading to chronic anemia. So these are the various effects which leads to, ultimately the renal functions are decreased, and if not diagnosed on time, and not only diagnosed, managed on time, these patients who are potentially curable may lead to chronic renal failure and dialysis. In our May session, we discussed about this, the basic understanding of hyper-parathyroidism and chronic renal failure. In that session, we discussed about a case who had recurrent stone formation, and during one of the procedures, he developed pyelonephritis. During PCNL, he developed pyelonephritis, bilateral pyelonephritis, leading to chronic renal failure. Ultimately, that patient landed up for dialysis. Now, this patient was so crippled. When I first saw the patient had a adenoma-like lesion. So we were confused whether it is the primary hyperparathyroidism which was missed around 13 years, for last 13 to 14 years he was forming the stones, or it is a tertiary hyperparathyroidism that has now developed. Okay, so that was the confusion. And now, so what is the post-parathyroidectomy follow-up studies? Okay, so there are various studies on this. Important ones I have picked for you. Like if suppose we have operated, it has been found that the chances of nephrolithiasis has drastically come down, especially if these nephrolithiasis was due to PHPT. So PHPT induced nephrolithiasis, the incidence comes come down very significantly. Okay. There could be a possibility the patient may have multiple other factors, but at least the PHPT induced renal stone formation, it is almost completely cured. Now, following parathyroidectomy, the deterioration of renal function is also drastically improved. So, following following parathyroidectomy, it has been found that the the renal function significantly improves compared to those who are conservatively managed. Similarly, skeletal development, the bone mineral density is significantly improved following parathyroidectomy. Because as Pankaj sir said, these bones are very hungry. These are demineralized. As soon as we remove the offending gland, the bones start grabbing the serum calcium. The patient becomes hypocalcemic to the extent that they start developing tetany, that we have to provide the calcium from the IV line. So before surgery, we were trying to lower down the calcium. After surgery, immediately after surgery, within 12 to 24 hours, we have to start IV calcium so that they don't go into tetany to this extent. So they have a significant improvement in the bone mineral density. Not only that, their cognitive compromise, their cognitive dysfunction, it improves. They start feeling better. They start feeling more good. Like the patient, she said, after surgery, I was feeling like something went off from my head. The dyspeptic symptoms, GI symptoms, everything improves after surgery. So, friends, the take-home message from my side, from our team, is that like recurrent nephrolithiasis is a major concern, because without kidney we cannot live. A healthy kidney is very, very important for a healthy life, a productive life. PHPT is an important cause. PHPT is not that rare which we used to once think about. It is very common. Important is that we are not able to diagnose because of lack of information. It needs dedicated investigation whenever it is suspected. It is completely curable under specialized care. Results are really rewarding, both for the patient and for the clinicians. And you know, friends, eye sees what the mind knows. So until unless we know about this entity, we are not going to detect, diagnose such cases and make a remarkable difference between in their life. So with this, friend, I would like to thank you all for your patient hearing, and I now request Pankaj sir to, now he can take over the questions, and our guest faculties may answer those. Thank you very much.
Thank you, Dr. Sudhi, for excellent overview about this hyperparathyroidism. Now, the most of the reference which we get for hyperparathyroidism are actually secondary hyperparathyroidism cases, and mostly with low vitamin D. So I would say that in my OPD practice, most of the patients which we get are because of secondary hyperparathyroidism. Hypovitaminosis D is very common, which leads to little bit fall in serum calcium, which stimulates parathyroid glands to increase parathyroid secretion, which is secondary hyperparathyroidism. So, friends, in OPD, asymptomatic patients or patients with some bony aches and pains, which are referred to us with hyperparathyroidism, most of them they are actually secondary hyperparathyroidism, and which we need to take care of. So, thank you once again for wonderful presentation. Any expert comments from our co-panelists, please? Dr. Paul, you
Hello,
before I
can you hear me?
Yes, sir,
Thank
very
you
well,
for that.
very well, sir.
It was an interesting case, especially the combination with the thyroid. I think there are a few points here, especially me working in the southern part, we do see a big difference in incidence of renal stones. Actually, as you say, the northern belt has a much higher incidence. So I would like to know the epidemiology from the endocrinology or urology opinion, because looking at statistics now, worldwide data, is about lifetime risk 2% and 10% in women for having stones. Do we have some kind of data in India? We're not aware. I saw one say
up to 25% in northern India may have a lifetime experience of stones. Is it that common?
Not exactly, we don't have any idea, but I think Dr. Vikas presented that around 5% of the patient with recurrent urolithiasis, they were PHPT. But in PHPT, how many patients were had renal stones? I think, sir, we lacked the study, and we lacked the study because of
stones in general. Stones are a very common problem, and we know it is higher in the north than the south. That is definite. But how is there any epidemiological data about stone prevalence?
Dr. Vikas or Dr. Vimal, they may
So
answer.
it is definitely more in North India. I don't have exact data, but it's definitely more in North India because I came to know this about our southern colleagues and my southern batchmates and seniors that they have very low incidence compared to North India of stone disease.
The second point is about whether an initial experience of stones requires a metabolic evaluation. I think guidelines are differing on this. I myself had the experience of a stone 3 years ago, so I can say with personal experience, there was a precipitating factor of dehydration because I was involved in some summer, abnormal activities, moving house and all that. So they decided actually not to even do the metabolic evaluation. So how would you go about a primary stone patient? Would you recommend full metabolic evaluation, or do you go for certain high risk features?
If I share my experience here, that whenever you fall out from institution and you join practice, then for some years you are very aggressive. So initially for initial 2, 3, 4 years, I used to investigate all my patients with history of renal stone. I never got anybody positive for any in this metabolic factor. So I stopped doing that. But you are right in saying so that patient with first stone formation may not actually require metabolic workup, but if second or multiple times, definitely those are the high risk patients who need metabolic workup in the day.
And I think as you brought up, that seems to be our problem actually, that the ones with more recurrent multiple stones are getting missed. Forget about the first stone formers. And
as a general, what we do, if anybody who forms stone, there are chances that at least 20% chances that he may again form a stone. So is the best way, our best protocol is that if the stone is removed or stone has come out, it should be sent for analysis. And if it found out to be a calcium phosphate stone, uric or something, not calcium oxalate, then one must go for basic metabolic workup. If it is a calcium oxalate, then there are high chances it may be because of dietary or low urine output or low intake of water kind of. But if it is not calcium oxalate, then one must go for metabolic workup, 24-hour urine test and everything.
Thank you. If it is calcium oxalate, then
calcium oxalate is mostly dietary stone.
You don't need evaluations.
So don't need that much. But if the patient is forming recurrent stones, even calcium oxalate, then one must go ahead with the metabolic workup. But if it is not calcium oxalate, it's calcium phosphate or other stones, one must always go for 24-hour urine testing and basic metabolic workup.
Can I ask Dr. Pathor to
I think I would like to differ in all recurrent cases, whether it is of calcium oxalate or irrespective of stone composition, we should go for metabolic evaluation. Not only, we should not leave oxalate stone formers.
He is asking, he is saying it about the first time stone former.
No. First, we can leave first time stone formers in case of oxalate stone formers, but if any patient is having recurrence, we should evaluate all of the patients.
Definitely.
Okay, fine. I think the general consensus is definitely recurrence, but may not be first. The pickup will be too low in first time.
What we practice in our department is that because it's an academic institute, we do for patients who are young, for pediatric group patients, for patients who had recurrent or recent past history of stone, we do send it even if they present to us for the first time. Like Dr. Pankaj said, the yield is very low. You might screen thousands of patients and you will pick up very few. But for academic purposes, yes, we should send. But then if you have a patient who's having a recurrent stone, has got bilateral stones, has got a picture of nephrocalcinosis, then we will definitely send it up in the first shot itself. And after we have started doing our FTIR analysis of the stone. If we find a calcium phosphate stone, we send up the analysis then and there after stone removal.
And second problem is that you don't get easy access to laboratory who are doing 24-hour urine testing, all the basic metabolic panel. So it's also different, and even other crystallography or stone analysis. So in Dehradun, I found if you ask somebody that you have removed the stone, if you ask that get it tested, then they have to send it to some metro city or somewhere else. Even 24-hour urine testing is difficult. So ideally, because any patient, as a you can say the data says that there are almost 50 to 20% chances that he may again form a stone. So there means you have easy access, or one can go ahead with this thing. Then testing is no harm in doing.
I would like to metabolic testing is not easily available. Yes, I agree.
Yeah.
Metabolic testing is not easily available, and we have to convince the patient for to get it done. But and
in my last
like in Meerut, I always send my patient for Ahmedabad, Urology Ahmedabad. So it's a difficult task to convince patient to send urine to Ahmedabad. So
basically,
yes,
what I
there are challenges, but we have to overcome the challenges.
Okay,
I will like to add one point here that okay, testing stone is the most difficult thing. Not many labs have this facility. Testing 24-hour urinary calcium is again may not be convenient and done everywhere. Serum calcium, which is very common and it is very fallaciously done by most of the labs. Remember, serum calcium assay has not yet been evolved to a very good extent. So not good lab, most of the labs they do it incorrectly. So whenever we are basing our diagnosis on the basis of this serum calcium, we need to go for a very good lab. So serum calcium, otherwise most of the labs they keep calcium on the lower side. So I have made this thing very clear in my instructions that if you are going for serum calcium, number one, it should be fasting. Avoid using tourniquet while withdrawing the sample. And thirdly, go for a very good lab. May not be available in your local region. May send it to a good lab rather than testing it anyway.
So, sir, how can we identify that the following reading is not good, is not right? Like which lab is right, which lab is not? But there are so many colleagues are also doing so. Like, how can we say this? Any
Probably
particular
calcium, it needs something different. That's my like you can say a personal unpublished data biased opinion. But for last 24 years, I'm observing this thing that I tend to repeat calcium, and then I find that the things are altogether different. So many times, most of the time, I don't believe on calcium level, which is provided by most of the nearby labs.
Okay, fine. So, actually, one question I want to ask from Dr. Partho. Dr. Partho, what do you think? Like, what could be the possible causes why this patient was missed for last 13 years, despite repeated encounters with the doctors, urologists, various urologists, prominent urologists, even nephrologists she had visited. But what could be the possible reason? Because you are an urologist, so you can tell us in a better way.
One of the reasons I might that might have contributed to is that they might have taken treatment in various different centers at different particular times, and many times record keeping can be poor. So patient may say some vague recollection of stone being there, and each person takes it as an independent unit. This thing, and they might have been far between. The frequency might have been far between. But yes, the to reach out to check parathyroid in a patient with recurrent stones requires a certain amount of clinical suspicion. I mean, the natural instinct is not to evaluate. So if you have that clinical suspicion and patients who are performing a particular kind of soft stones or are passing it out very fast. I mean, in a more academic cycle, the suspicion comes to us much more naturally and we send it out. But I mean, multiple factors would have gone, and I am assuming the patient might have been told, like Dr. Vikas correctly said, to get an evaluation done because of the cost factor. They wouldn't have done it. A lot of factors would have gone in. So that's why the physicians perceive the fact that you've been forming stones and this can potentially impact your kidneys in the long run, instead of individually looking at as single episodes which being dealt with in various ways, and convince the patient to get an evaluation done. It's much, it will give us better yield, I think, is what I think.
Dr. Vimal, may I ask you the same question? In your clinical practice, what could be the probable reason why the patient was missed? Apart from, like, I can understand the cost factor, but yeah, do urologists really ask for the metabolic workup, or they just assume that because it is costly, the patient will not? Is it a routine part that you look for it in recurrent cases, or what exactly? How do you work up such patient?
Yeah, I think if I am heard clearly because your voice was not very clear. I think what you are asking that we ask for the patient for metabolic workup and they don't turn up.
No. Do you ask for metabolic workup in recurrent nephrolithiasis cases, or we just think that these are recurrent stone formers, hypercalciuria is the most common entity, and nothing can be done? We just put them on either thiazides or whatsoever. So what is your approach? We just put them on medicine, recurrent stone formation, we just remove them out, or we really sincerely work up for the cause?
Not very nice what happens as we discussed before also. We don't have facility where we can get this thing done, metabolic workup and 24-hour urine testing, because as a standard protocol, what we think, 24-hour urine reports, they should be matched with the stone crystallography or stone analysis. If they are matching and they are leading to somewhere towards like hyper-parathyroidism or some other uric acid stone or some other, that means the stone analysis should have some matching with the urine 24-hour urine testing. Then we go for basic metabolic workup also. But problem with us is, like in Dehradun, we don't get labs where we can get 24-hour urine testing even and our stone analysis. So I will say kind of that we ask patient to take thiazides 12.5 milligram prescribe and ask them to take at least 3.5 liter of water so that they produce 2.5 liter of urine every day.
So
and this kind of supportive.
Okay, so what I can understand from what you have told, because of lack of there are logistic reasons, and also logistic reason, you are not able to work out this patient, and you ask them just for medical treatment, conservative treatment. So sir, Pankaj sir, I would like to ask you, in such scenario,
just let me say one word about this. Basically, when a person is coming with one acute problem like that of a stone or like fracture, entire energy is diverted towards getting rid of these acute ailments. So at that time, most of the things are overlooked. By the time patient feels better or surpasses the acute events, by that time, many a times we miss this opportunity. Many times patients don't care. If I give an analogy of gestational diabetes mellitus, I treat that patient for 9 months very well. When I ask them to read to us after 15 or days or 1 month of delivery, nobody comes for future follow-up. So that is the problem. Once acute things are over, the things are gone. So probably if we plan our things that later on we will do it, it will be waste. So why not do it then and there only at the time of acute workup? It may be financial, but many times it may give us some opportunity to screen.
But sir, a basic problem, one can say, here we do have not many patients with stones. Like we urologists are the basic bread and butter is PCNL and US, all these things. But thing is, we don't have proper. I have 3-4 patients recurrent stone former. We know there's something lying there, and we are not treating. But whenever we ask them, even for a system EBA scan or something like that, I said, if you are not getting all these things, at least get that scan done. If we find out something, we'll send you to endocrine surgeon. We'll get it done. So they say, okay, sir, this is costing again 12, 15,000 and 20,000. I have to go to Delhi for that thing, so I'm not going anywhere. You next time again you.
As far as a parathyroid goes, I mean, our department has, our radiology department has done a very good job of doing an ultrasound screening to see if there are any parathyroid nodules. That also is a very good initial screening to see if there are any obvious parathyroid nodules. We do send them for that once we find the calcium is high or the recurrent. So, what do you say about this, sir? So, Paul, sir.
Localization study should never be done as the first line screen. So
I agree, but short of a sustainability scan.
and then
That's true. But thing is, you don't have 24-hour urine analysis testing. You don't have stone analysis. You have nothing.
Absolutely.
Patient comes and repeat stone formation. When you are fed up with operating the same patient every 8 months, 1 year, then you ask them to get done something. At least we can find out the reason why you are forming so many stones and so repeatedly. So I mean,
sir, Paul sir and
I
Pankaj sir
agree.
may correct
I
me.
agree with Dr. Vimal here.
Paul sir and
Completely agree.
Pankaj sir may correct me, but for in answer for you, Dr. Vimal, I can very well understand that there is a problem with 24-hour urine analysis, stone analysis. But the important thing is, first of all, we must understand कि any patient with suspicion of hyperparathyroidism don't jump directly to localization. First, biochemically confirm. अब asking for serum calcium, inorganic phosphorus, alkaline phosphatase, renal function, 25 hydroxy vitamin D, and intact PTH from a very good lab, standard lab like Lal Pathology, Ranbaxy. It is readily available. With the other blood investigation, you ask for renal function test. Obviously, before doing any intervention for CT scan and other things, renal function test is mandatory. With that test, you ask for these investigations also. So these blood investigation will help you a lot. Apart from when it is biochemical, but ask from a very good lab, not from a local pathology, because these investigations are very rarely requested. So they require certain agents which local pathology they usually don't have. But in high volume centers like Lal Pathology, PathKind, they follow standard protocols. Usually their reports are standardized. So very high chances that we may pick up the patients from there. And if you will tell them that with these investigation your chances of stone recurrence will drop or you will be cured, they will certainly sure to do follow your advice. If you will tell that if you are found to be positive, then आपकी जो समस्या है वो खत्म भी हो सकती है. Then I don't think any, and these are very simple tests. First thing.
No.
Secondly,
But I'm asking, as you mentioned in your presentation also, there are patients who are normocalcemic, even IPTS level is hardly raised, just beyond the upper normal range. So in that patient, what do you do? Do you ask for needle imaging or something?
No. The thing is, actually, here comes the specialization. Because these patients primarily present to urologist. So first of all, urologists need to understand that there is something need to be worked up. Basic workup they can ask from their patient. But if they're not able to interpret the results or they still have a very high suspicion, then they should take the help of endocrinologist or endocrine surgeon because they are trained in dealing such patients. Why it is important? It is not important for you as an urologist or me as an endocrine surgeon. It is important for the patient because one whole life is under your care. And not only that whole life, the whole family may be dependent on that particular person. If with this interaction we are able to develop any level of understanding to the extent that we are able to help out those patients who are potentially curable, then at least our things are done. At least our motive is accomplished. Okay, so the important point that I would like for those urologists who work under compromised situation, at least go for the blood investigation from very good lab. Ask the series of investigations which I have told. These labs have their collection centers in small towns also. So it is not a very tedious task. They follow the strict protocols of their agency. So even the 24-hour urinary calcium they do. So that is not a big deal. Important is what I said in my last comment. Eye sees what the mind knows. So through this forum, we are trying to develop this, we are trying to learn so that our eyes have a broader vision. We see the same patient but with a broader aspect. So this is my important message to all the urologists who are with us today. Sir, please correct me if I am wrong anywhere. Paul sir, Pankaj sir, please.
Yeah, and I think the classic teaching definitely is you need a biochemical diagnosis before you go for localization. But I think point was raised that patients tend to, get tired or they have other priorities when we ask for big workups. And in the Indian situation, if you have a post-socioeconomic condition patient who's got recurrent renal stones and problems, I don't see any harm in doing a screening of the neck of the ultrasound when you're doing the stone evaluation. I think it may be even a good pickup point. I think we have to think outside the box when we deal with our patients because they don't follow the rules, as I said. You can think whatever protocols you want, but the 90% of the time it doesn't work in the majority of our patients. I just have two quick points. Sorry, I'll have to go shortly. So, I think one of the points raised was the association of thyroid goiter along with parathyroid. So, it also depends on the basic goiter incidence in the population. But the important point with hyperparathyroidism is a thyroid nodule has a higher risk of malignancy when it's associated with hyperparathyroidism, which is brought out in one of your papers. You quoted also the risk of malignancy, definitely in thyroid. So, endocrine surgeon, when dealing with hypoparathyroidism, when doing localization, if you see an indeterminate nodule or any atypia on cytology, have a low threshold for including thyroidectomy because the chance of papillary cancer is much higher. That is one. This other is about the presentation of hypoparathyroidism in our country. In the southern region, we see maximum bone disease, second stones, and a combination of both. And we also have a high rate of pancreatitis, as you mentioned, is almost 8% of our patients are presented with pancreatitis. And when you apply the pancreatitis protocol, you have to check expecting low calcium. You actually find a normal high calcium, and that has led to diagnosis in many patients. Regarding the mortality, we don't see much mortality, fortunately, with hyperparathyroidism. The only ones I've seen are the ones where they're malignant, that's a parathyroid carcinoma, long prolonged courses, and expired or metastatic disease. Again, very slow. So I think that will be regional variation. We know that India is such a diverse country that each of us sees a different population. We have our own unique problems. So these are the things. I mean, 90% of our patients present symptomatic. Still, only 10% are picked up by screening. Whereas it's the exact opposite in high-income countries where 90% are asymptomatic screen detected. So that's another which may change in the future, but still, I think by and large, we only get symptomatic patients.
Sure.
Thank you.
Very important. But one important point I would like to discuss with you. One interesting slide Dr. Vikas put was the thiazide provocation test. I have never used that, but I think it is very promising, especially in cases with normocalcemic hyperparathyroidism, something like this. We usually get confused with whether the patient is really hyperparathyroid or there is some borderline gene. So if any idea about is it really being used or what are the various doses, if any experience, because I think it is promising. We do get such cases with borderline calcium, borderline parathyroid, and we are not able to understand whether we should label this patient as hyperpara or not. So can we really do it or to screen out our patient?
Sorry, is that a question?
Yes, sir. It was a question, Sir Paul, sir, or
Normocalcemic hyperparathyroidism. Yes,
Sir,
just yesterday we had
this thiazide provocation test. Can it be helpful in patients with like normocalcemic hyperparathyroid, yeah, hypercalcemic, normocalcemic hyperparathyroid? Can we use this thiazide administration test? Will it be
we don't
helpful?
use the thiazide test normally. No, we do, except yes, there is normocalcemic hyperparathyroidism which if has presentation of any of the clinical syndromes or the bone affectation, then we take it as, we say, inappropriately elevated PTH for that level of calcium. And if there is presentation of disease, it is taken as primary hyper-parathyroidism. I'm not aware of the use of thyroid provocation test. The endocrinologists can probably educate us on that.
I never heard anybody doing so. I never did it. Didn't hear that anything.
Okay, and sir, just last word from all the guest faculties. If suppose a similar case would have presented to your institute, would your line of management would be the same or something different?
Sorry, not able to hear you clearly.
Sir, if the same patient would have presented to your institute, maybe to Dr. Partho first and then to you, would the line of management would have been the same, or you would have done something extra in such type of
No,
patient?
I think what you did was fine. The fact that you caught on to the history of recurrent nephrolithiasis and investigated it further was fantastic. I think we would have also taken the same line and made sure that we found the root cause of recurrent nephrolithiasis.
Okay, and Paul sir also agreed to this.
Yes. I think the management was fine, and here, of course, you had a large goiter. I just wanted to reiterate the point. If you have a small, even a smaller nodule, you have to look at it especially in this setting. Many times we have taken out small nodules which have turned out to be papillary in association with hyperparathyroidism.
So any other question from any of our participants? Our guest faculties are here to answer all those. Okay, so I am so thankful to all the participants, especially our guest faculties, our moderator, and our participants, our co-speakers, Dr. Reena, Dr. Vikas, Dr. Bhavna, Dr. Annie. They are such wonderful friends. They are always with me to learn something new. And I learned really lot of things from all of you. So many things I really didn't know, and I'm hopeful all my other friends, all the participants must have also experienced the same. And it was really a wonderful meeting. Wonderful meeting. I enjoyed a lot. And I don't know about the others, but I really enjoyed a lot. And with this, friends, please be ready for our upcoming meet in December. That will be a breast meet. In that breast meet, we will be discussing about the role of radiation therapy in breast cancer, what the clinicians must know. So that will be a very basic understanding of the radiotherapy in breast cancer. For all those who deal with breast cancer, please do join us. The details will be shared shortly. And as a protocol, all the proceedings of our program are being recorded and will be uploaded on YouTube for our future references. So anyone who has missed any point can revisit and can see the discussion again. And I'm so grateful for everyone for giving their precious time.
Thank you. Good evening to all. Thank you.
Thank you, and I hope we'll meet again. Maybe some other opportunity. I'll try to steal some other opportunity to invite you again for this forum. And I hope you might have also learned something new. Anything, we still have 1 minute to share or ask. We can ask. Otherwise, we can leave the meeting after that.
Well done to all the presenters. I think case was very interesting, and I've learned. Thank you.
Thank you very much. Any few words for our program are that now I have sent about that will give me an encouragement. Yeah. False. I have sent you about the motive of this program. This is an integrated program. Like in our other forum, all the endocrine surgeons meet, but in this forum, all the other specialties who are involved in the management of that case, we all meet. And the pathologists, radiologists, they get an opportunity to learn how their investigation actually, they see the gross, they see the histopathologies, everything. So they also have an impact in their mind that how their FNAC is affected.
But I have, Dr. Sudhi, I have a point to add on a lighter note. whenever you see a patient, refer first to a urologist.
Obviously,
Always.
it is a urological problem. Without urologist, we cannot do it. Because kidney anyhow has to be managed by the urologist. I cannot manage.
Because hyperparathyroidism consists only 5% cases. So always
recurrent stone.
refer first to
Any
urologist.
stone, it is your
Urologist
domain.
will investigate and then send it back to you.
No problem, no problem. Stones, renal stones are your domain. I cannot intervene or cannot do anything. What I can do is
I
just
think
to
Dr.
screen
Partho and
them.
Dr. Vimal will agree with.
But what I can say from my side, now that we know about, we have discussed so elaborately. Uh, uh, Investigation is not a big deal. Blood investigation can help us a lot. Not in all patients we are able to do 24-hour urinary calcium. Like in this patient also, we were not able to do the 24-hour. It is not like that the patient was not able to afford. Due to some reason, we were not able to prescribe. But this is not an hindrance. So many standard labs have their collection centers, even in the small towns. So this is, I don't think this is an excuse. Important is that maybe because we never discussed about it. Now that we have discussed, at least those who have participated, they must now upgrade their clinical skill to the next level so that their patients are benefited, because it is not only just a removal of a stone. When your patient is cured of this renal stone, you can understand what the fame you will get, that this particular doctor is able to cure any patient with recurrent stones, isn't it? So just take this into your consideration. Screen out all the patient. With proper integration, we are able to manage all the patient, because like kidney stones I cannot manage. Similarly, parathyroid gland, the urologists are not able to manage. So it is a symbiotic relationship. So we are in this forum, we explored this symbiotic relationship. We cannot do alone. We have to work as a team in this type of patient. Okay, so this is my last take home message, that please screen for all your patients. I have already told what we need to screen as blood investigation, and just try to find out if there are any subset of patient which can be cured. Please consider those patients. So with this, I would like with this, I would like to thank you all for your patient hearing, your active participation. It was really very encouraging for me. It is always very encouraging for me. Thank you very much. Now we can leave the meeting, and
Thank you.
we will certainly meet in
Thank you so much,
another
ma'am.
meetings
It was a
also.
nice
Thank you
lecture.
very much. Hi, Dr. Annie, Dr. Reena,
Thank you,
Thank you,
Dr.
Dr.
Sudhir.
Dr.
Thank you,
Sudhi.
Sela, you
Dr.
are
Vimal.
always there with us
Thank you,
in
Dr.
all our
Sudhir.
meets. Dr.
Bye.
Vimal, Dr. Partho, everyone, Dr. Vikas. Thank you very much. Bye. ये सभी ऐड हो गए थे। अच्छा, ये बाद में होगा। इसमें थोड़ा स्क्रीन स्लो चलती है।
हाँ, आ जाओ अंदर, आ जाओ। खत्म हो गया, आ जाओ अंदर।
मैक्सिमम पार्टिसिपेशन कितना था? मैक्सिमम पार्टिसिपेशन कितना था? 20 के करीब था। ठीक है।
Yeah.